So recording is started.
Okay. We are live today now. We are on.
Yes,
Yeah.
sir. Yes, sir.
Okay. So good morning, everyone. This is from FOGSI ICOG. I am Ashok Kumar, welcoming you for this today's tutorial of ICOG. This is on every second Sunday of the month at 11:30 a.m. in the morning. And we always do case discussions on important topics for the benefit of our participants and the fellows and members of the ICOG. Today, we will be discussing two cases on prolapse of the uterus. One is on nulliparous prolapse, and second is in a classical case, what we see in a perimenopausal woman. So we hope that our viewer will find it very useful. And before I start, I would like to express my sincere thanks to FOGSI President, Dr. Rishikesh Pai, ICOG Chairperson, Dr. Lakshmi Shikhande, for giving us this opportunity to be here and to interact with all of you and have this presentation in the form of tutorials. And this is the very long program going on for last 1.5 years. And every month on the second Sunday at 11:30, we are doing this program for the benefit of our fellows and members. And I am very thankful to our faculty today, Dr. Ashish Kumar Mukhopadhyay, Nilima Patil, Dr. Rajkumari Paneshwari, and Dr. B.R. Sharma and Dr. Sarita Agarwal for sparing their valuable time and will take part and give their inputs in the discussion. And we have today students from Tamil Nadu, Chennai, and from West Bengal, Kalyani, and they will be presenting two cases of prolapse of the uterus in different situations. And you know, our endeavor is always to have wide participation from different parts of the country. So today we have students from Chennai and Kalyani, and we have faculty, Dr. Ashish Kumar from Calcutta, Dr. Nilima Patil from Bijapur, Dr. Rajkumari Paneshwari from Imphal, far northeast, Dr. B.R. Sharma from Mandi, Himachal Pradesh, and Dr. Sarita Agarwal from Raipur. And I take this opportunity to welcome our ICOG Governing Council members, Sneha Bhoyar, and I think Shobha Gudi Madam is also with us. And I now take this opportunity also to welcome and invite our Vice Chair ICOG, Dr. Parag Biniwala, to say a few words.
Thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, the Indian College of OBGYN, and it's indeed a pleasure to welcome you all in place of Dr. Lakshmi Shikhande, who's a little tied up for this ICOG tutorials. ICOG tutorials is the brainchild of our secretary, Dr. Ashok Kumar, and he has been running it successfully for more than a year and a half now. The basic idea is to have the students make case presentations to different examiners from all across the country. So they get exposed to examiners from different zones or different areas, which would definitely enrich their knowledge. So once again, welcome all, and let's have a great learning experience. And I must appreciate efforts by Hafizur, who's our governing council member and who's running this program rather successfully. Thank you.
Thank you, Dr. Parag Biniwale. And I must express my sincere thanks to Dr. Hafizur Rahman and Dr. Ashish Mukhopadhyay, with whose coordination, support, and cooperation we are able to do this program every second Sunday of the month. And now I just hand over to Dr. Hafizur Rahman for further proceedings. Before that, I welcome all of you for this tutorial, and I hope it will be informative and knowledgeable and useful to all of you. Thank you.
Good morning, everyone. Thank you, Ashok sir, for highlighting words, as well as I'd like to express my sincere thanks to the FOGSI President, our Chairperson, and Vice Chairperson, Dr. Parag Vinyala sir, also for all the blessings. So as our secretary told, today we'll be having two important cases, that is on genital prolapse as well as uterovaginal prolapse in perimenopausal age group. So we have our all last 1.5 months programs recording in the ICOG website. So student, if anyone have missed any program, can go to our ICOG website and have view those programs. But today's program is another important program, and I'm sure if not every student, at least every alternate student in postgraduate examination will get cases of genital prolapse. So this session is going to be very much important for them. So for the first case on nulliparous prolapse by the students of Sri Ramachandra Medical College, Chennai. So Dr. Bhavani Sri and Dr. Nivedita Krishnan will be presenting, and those who are very efficiently guided by Dr. Professor N. Palaniappan and Dr. Geeta. So they will be presenting on the first case, and the second case on uterovaginal prolapse in the perimenopausal age group will be presented by students from College of Medicine and JNM Hospital, Kalyani, West Bengal. So Dr. Sharna Nandi and Dr. Sanjit Patil will be presenting the case, and they are very, again, aptly guided by Dr. Manidipal sir. So we have eminent national faculties like all other times from all over India, and Dr. Ashish Kumar Mukhopadhyay, who need no introduction actually, has been consistently there almost in all the programs. He's professor and of OBGY as well as principal of CSS Medical College at Kolkata. So sir will be joining us shortly. Then we have Dr. Nilama Patil. Madam is a professor of OBGYN at BLDE and SBM PMC at Vijayapur. She has many publications and has an interest in research, has been an invited faculty. We have got Dr. Rajkumari Praneshwari Devi, madam. She's a professor at Regional Institute of Medical Science in Imphal, and as she's also actively involved in FOGSI as well as in research and other activities as a good educationist. Then we have Dr. Professor B.R. Sharma. He's professor and head at Sri Lal Bahadur Shastri Government Medical College at Mandi, Himachal Pradesh. Sir is also a distinguished professor as well as an academician. Now we have another eminent teacher, Dr. Sarita Agarwal, madam. Madam is professor and head at All India Institute of Medical Science at Raipur, and she has many publications as well as research and other contribution in the field of education as well as in the FOGSI. So I would like to welcome all the faculty, students, and all the delegates from all over India, and I am sure it will be very happy as well as fruitful learning for all the students as well as all the delegates. So without having any further delay, I would like to request Dr. Bhavani Sri and Dr. Nivedita to please share your screen and start presenting. And I request all the faculties to take over the proceeding and take over the students to take their case through. So Dr. Bhavani and Dr. Nivedita, please share your screen. Yeah, please make it slideshow. Yes, I request our faculties, Dr. Ashish, Dr. Nilama Patil, Dr. Rajkumari, Dr. B.R. Sharma, and Dr. Sarita Agrawal to take over, please. Please start presenting and introducing yourself.
Good morning, sir and ma'am. I'm Dr. Bhavani Sri from Sri Ramachandra Medical College. I will be presenting the history. And I'm Dr. Nivedita Krishnan, sir. Good morning, everyone. Shall I start, sir? 24 years, Mrs. X, Nulliparous lady, married since 2 years, coming from Kanchipuram district, unskilled laborer by occupation. She is a construction worker. Qualification class 10, religion Hindu, occupation of the husband farmer, belonging to the lower middle class according to the modified Kuppiswami's classification. Came to the OPD with the complaints of something coming out of the vagina since 1 year. History of present illness. The patient was apparently normal 1 year back. Then she noted something coming out of the vagina, which was insidious in onset and gradually progressed to the present size over 1 year, more prominent during the defecation and lifting heavy weights, and reduced on its own while lying down. She also complains of backache on and off, which is generally more towards the end of the day and relieved by rest. History of lifting heavy weight at workplace for the past 5 years. Patient is sexually active and has no difficulty or pain during coitus. No complaints of difficulty in initiating micturition, straining while passing urine, incomplete voiding, slow urine stream, or dribbling of urine. No history of increased daytime frequency of micturition or painful micturition. No history of involuntary leakage of urine while straining or coughing. No history of fever or burning micturition. She has a regular bowel habits and no history of incomplete emptying. She has no history of white discharge per vaginum or postcoital bleeding. No history of chronic cough or chronic constipation or abdominal distension. Menstrual history, attained menarche at 12 years of age, regular cycles, 3 to 4 days of flow every 28 to 30 days, changing 2 to 3 pairs per day, no history of dysmenorrhea or passage of clots. Her LMP was on 20th of January, and marital history, married to Mr. Y for 2 years, non-consanguineous marriage, he is former by occupation, sexually active, and has no coital difficulty or pain, no history of contraceptive usage, planning for pregnancy, and no history of treatment for the same. Past history, no history of bronchial asthma, chronic cough, or chronic constipation, no history of tuberculosis in the past or connective tissue disorders, not a known case of hypertension, diabetes, or thyroid disorder, no history of pelvic or spine surgeries in the past. Family history, no history of connective tissue disorder in the family. Personal history, no food or drug allergies, non-smoker, and socioeconomic status, lower middle class according to modified Kupusomi's classification. Diet history, mixed diet. Total calorie requirement of the patient is 2,695 kilocalories per day, and total calorie intake is 2,595 kilocalories, and total calorie deficit is 100 kilocalories per day, and total protein requirement per day is 45 grams per day, and total protein intake is 43 grams per day, and total protein deficit is 2 grams per day.
Can I proceed with the examination, sir?
On history-wise, what are the differential diagnoses you're thinking of?
It can be an retrovaginal prolapse, ma'am, or fibroid polyp.
Okay.
Gardner cyst.
Means what are the differential diagnoses for mass per vagina? Okay, one is prolapse, other one is polyp. Anything else?
Fibroid polyp. Gardner cyst, ma'am.
Okay.
Chronic inversion of uterus, ma'am.
Yes.
Along infravaginal elongation of cervix, ma'am.
Okay, congenital elongation of the cervix.
Yes, ma'am.
Okay. Okay.
Can I proceed, ma'am?
Amit, when you're talking about the differential diagnosis, you can proceed in a more systematic way. Start from common to least common, or start from below to up. So here in the such cases, we should proceed with the common to the most common to the least common. So of course, you should tell them the cervical elongation, then uterovaginal descent, and then Gardner cyst, then other like Bartholin also sometimes they say something coming, and then even sometimes the vaginal tag and the lipoma. In the young patient, they just present as something coming because they cannot differentiate whether it is coming out from the vagina or it is just hanging from the vagina vault, from the introitus, right? So you can be more systematic. Good.
Okay, let her finish the presentation first, and we'll cross, I think.
I think we should continue with the history part where the deficiencies are there. Then we will be more methodical as it is an examination process, you know. So if I look at your history part, one more thing when you're saying the no about the n number of the complaints, and that the no urinary complaints like, and then you can enumerate all urinary complaints, right?
Yes,
Okay, ma'am.
And then no bowel complaints like, and then you can tell what are the bowel complaints which can be associated with the prolapse of the uterus, right?
Yes, ma'am.
And then
Yes,
I just wanted, you have taken in a history, there is no history of connective tissue disorder in the women and the connective tissue disorder in the family. I just want to tell you, if the patient is coming from the uneducated area, how she can tell about the connective tissue disorder. And what specific history you're going to talk to just you want to rule out the connective tissue disorders?
We can ask for patients can have any dislocation of the lens or any previous surgeries, eye surgeries, or a patient has any other hernia, hypermobility of the joints, any dislocations previously.
And yes, hypermobility of the joint, and then the continuous body aches and all. And if she's on some long-term medication, usually the connective tissue disorders are on a long-term medication, or they take often on analgesics as well. And of course, the other history of the like congenital weakness of the connective tissue, as you said, it is in the presence of hernia somewhere, or the history of some joint dislocations, right? So you need to be very specific on that.
Yes, ma'am.
Okay. You can go ahead with the examination finding.
Okay. General examination, the patient is moderately built and nourished with a height of 157 centimeter and weight of 50 kgs with a corresponding BMI of 20.3 kg per meter square. There's no pallor icterus, cyanosis clubbing, lymphadenopathy or pedal edema. Spine, breast and thyroid were clinically normal. Patient was vitally stable with a pulse rate of 70 beats per minute, BP of 110 by 80 millimeters of mercury, respiratory rate of 18 cycles per minute. Systemic examination, CVS S1 and S2 heard, no murmurs. Respiratory system, bilateral laryngeal present, no added sounds, and CNS, no focal neurological deficit. For abdomen examination, on inspection, the abdomen was flat, umbilicus in midline and inverted, no dilated veins or sinuses, all quadrants moves equally with respiration. Hernial orifices were free and no scars were noted. On palpation, no warmth or tenderness, no mass palpable. Abdominal muscle tone was found to be normal. Percussion, resonant note heard over the abdomen, no free fluid, and on auscultation, bowel sounds present. Pelvic examination, after obtaining verbal consent from the patient, she's examined.
Can you just stop here? Let's
Yes,
proceed with the importance of general examination in your case, right?
Yes, ma'am.
So as per general examination, you have mentioned the BMI is 20.3 kg per meter square. It is a normal BMI. Can you just tell me what is the importance of BMI of the women who is in a nulliparous prolapse?
Okay, ma'am. For example, the patient is on the overweight side or on the obese side, there is increased chance of prolapse because of the increased intra-abdominal pressure. And if the BMI is on the lower side, as in if she is undernourished, there can be prolapse because of malnourishment also, ma'am.
Nutrition deficiency. So that is one point regarding the etiological part, right? Is it going to affect your management part?
Post-surgical also, more concentration should be given to the nourishment.
Post-surgical or
I'm talking about the taking decision for which
Decision-
surgery. Is it
surgery
going to
and-
decide?
Sorry, ma'am.
Decision for the surgery, is the high BMI is going to affect your decision for the surgery?
Yes, laparoscopy. Yes, ma'am. The patients will have difficulty in doing the laparoscopic surgeries, ma'am.
Laparoscopy is rather easier than your
Easier than the
laparotomy
obese patient.
surgery, you know, in the obese patient. Maybe something like that you will prefer in vaginal surgery better in the morbid obese patient, or you prefer a laparoscopic surgery over the laparotomy patient, laparotomy in an obese patient. Is there any difference whether you're going to select the anterior sling, posterior sling, or the lateral slings and all? So these are the things which have the impact on that. We will be talking about that when we are discussing about the management part, right? And then you
Yes,
have
ma'am.
mentioned the spines are normal, right? How
that
do
was
you do the
needed for-
examination of a spine?
Okay.
Anything
Sorry, ma'am.
specific you
How-
want to comment on spine in relation to her nulliparous prolapse?
Any history of surgery to the spine, ma'am?
No, examination. You're in examination now.
You said spine is normal, you know, we want to know how to do the examination for the spine. This is very important, you know, because certain things which may not be visible. I just want to know how the spine can, abnormality can be the cause for nulliparous prolapse.
Any occult spina bifida, ma'am, that can be a cause also for nulliparous prolapse.
There can be visible spina bifida. You know, they can be occult spina bifida. And if she has a kyphoscoliosis, some spinal deformity, then again you have to think about whether you can do the surgery on the spinal anesthesia or not, right? And for the examination, you have to examine right from the cervical spine till the lumbar areas. And you have to palpate nicely with the thumb. That is important when to examine, right?
Okay, ma'am.
Okay. Then proceed further. Before, so you know what, go back. Before, yeah, I just wanted to know in your this history part, you not mentioned about the neurological problems in the past to the women. She might have had some neurological manifestation in the past that can also lead to the weakness of the nervous system, this innervation of the pelvic organ that can lead to prolapse. And similarly, in the CNS examination, you have to be very much methodical looking at the powers of the muscles, specifically of the lower limb muscles. So you should mention CNS is NAD is not an answer in a nulliparous prolapse, right? You should tell that the powers in both the lower limbs are normal, right? And the reflexes, the plantar reflexes and knee jerks are normal.
Okay.
Okay.
See what
Okay.
happens when we have a habit of writing normal, then we forget about that. Yes, I have to look for these things in the nulliparous prolapse, right? Okay.
Okay.
Yes.
Can I go ahead, ma'am?
And one more thing in examination is the hernial orifices are free. Do you find an hernial orifices on your per abdomen examination? Are the hernial orifices are there?
On palpation, we can find, ma'am.
If the defect is there, then only you can palpate. There's no inbuilt orifices, you know, so it's better to tell hernia sites are normal.
Okay.
Okay,
Okay.
that means that there hernia site, no defect is there. Then at the same time, you had to mention on the palpation. Okay, go ahead in the palpation part. So no, what is abdominal muscle tone is normal, right? Can you tell me how to test for the abdominal muscle tone?
Okay, ma'am. The patient is made to lie supine, and without flexing the knee, the patient is asked to lift the lower limb. And in case she's able to do that, or lifting of the neck without lifting the lower limb, either one of this is attempted. And if she's able to do that, then abdominal muscle tone is found to be
It is
normal.
not able to do it. When she do the straight leg raising test with both the legs raised simultaneously, you have to look at whether the rectors are standing out or not. Then you need to palpate how much firm the muscles are becoming. Okay, that is important. And why it is important to check for the abdominal muscle tone?
Sorry, ma'am.
Why it is important to check for the abdominal muscle tone, specifically in the nulliparous prolapse?
To decide on the surgery, ma'am. So if already there is a weakness of the muscle tone on the fascia, then will not be preferring the surgeries, the sling surgeries, particularly the rectus purandare surgeries, ma'am.
Anterior sling you won't prefer. Other than that, if you find abdominal muscle tone is poor, then you can think some muscular disorder, you know, and that can lead to, that can be one of the etiological factor. Sometimes it happens, patient does not have anything, but you find there's a generalized muscle weakness. So the abdominal muscle tone testing will tell you about that thing. Okay.
Can I go ahead, ma'am?
There's one more thing on the percussion part, as you have mentioned. Can you go back? Resonant note heard over the abdomen and no free fluid. What is the significance of having the free fluid?
Any
Ascites, ma'am.
ascites because of an ovarian mass or anything can increase the intra-abdominal pressure, which can be the precipitating factor for the
Any
prolapse.
grade of ascites will cause?
Sorry?
Grade of ascites, which grade of ascites will cause? See, grade 1, grade 2, grades are there no, in ascites. All kinds of ascites will lead to prolapse.
No, ma'am. Great.
Okay.
So if it is a huge ascites, then only one of it is
Severe
usually
grade.
not a causative factor. It can be a precipitated factor and an associated factor, you know, and it indicates some abdominal pathology which can help find out some associated medical disorder, and this needs to be taken into consideration when you're planning for some surgical intervention. I think the percussion, madam, are you agree with the writing the percussion resonant note heard over the abdomen, no free flowing? You know, percussion usually we write how? So you should tell ki all over abdomen the resonant note is noted and no shifting dullness, right? Because shifting dullness is elicited for looking for the smaller fluid also. Our concern is not that can be the precipitating factor, but our concern some associated pathology if it is there, right?
Yes, ma'am.
Okay, go ahead. All quadrants of abdomen like that you should tell always, huh?
What I can also add here, madam.
Yeah, please go.
Yeah, if I think if it is a normal finding, like we say about the chest and cardiovascular system, we can write also that abdomen is soft and normal, so that we can proceed with the other examination where we have the relevant findings.
Yes,
Okay, sir.
That will be least to invite the trouble.
Sir, we are not
Yes.
here for the troubles, avoiding trouble. We are trying to make that they should make all trouble over here, so they should be
Yes,
comfortable with the
yes.
troubleshooting consultants also. You know?
Yes, yes. So
I think I'll put a word here, Sarita.
So Ashish, welcome.
Yes, yes.
Now I
Thank you
have to
so much,
stop
Sarita.
talking anything, you
I
know,
have
once
been
you are
listening
here.
to the crossings that you have been taking. See, there are many things which can happen intra-abdominally, and it all depends in a PG level. It always depends on our findings, palpatory findings on palpation. Okay. Now, suppose there is the PG finds on evidence of free fluid in the abdomen, then only the question of fluid thrill, shifting dullness, etc. they come. Otherwise, what Dr. Ashok said is to a PG examining abdomen, they have been doing this for the last 3 years, a normal examination of the abdomen, including the muscle tone of the rectus and the intra-abdominal content, that is fair enough. I mean, even dealing with the case of nulliparous prolapse, all right, we are finding we have to drive the case to such a direction that, you know, the crossing also goes in the same direction. Otherwise, too many DDs will come and the students will be confused and they will have a lot of this thing in the process. That is what my suggestion is. And otherwise, also the timing is important because the students have got limited amount of time, you know, in presenting their cases. So I think that, yes, the PG level, you can excuse these things because in the undergraduate level, it is okay. It's better to be thorough and detailed in on all these things.
Yes, sir.
Okay, go ahead with your pelvic
Please go
examination.
ahead. Please go ahead.
After obtaining verbal consent from the patient, she is examined in dorsal position with good lighting and parts adequately exposed. With the bladder comfortably full, the patient to strain and cough, and no incontinence is noted. The mass is now reduced completely, and the patient is made to cough, and again incontinence is noted, and the patient is asked to void and lie in dorsal position. On inspection, the external genitalia appears normal. The cervix is seen protruding at the level of the introitus. Cervix appears healthy with no mucosal thickening, pigmentation, or decubitus ulcer. Speculum examination is done after reducing the prolapse part. Vagina appears pink, moist. Vaginal rugosities are present. No paravaginal defect noted. Cervix is pinpoint external loss noted. No discharge noted. No cystocele, enterocele, or rectocele noted. Uterine sound is introduced. The cervical length is measured to be 5 centimeter, and the intravaginal length of the cervix is measured to be 2.5, and therefore the intravaginal length will correspond to 2.5 centimeter. By manual examination, the uterus is completely reducible. The uterus is retroverted, size, mobile with free orifices. Rectal examination, skin crease around the external anal sphincter is normal. No hemorrhoids or rectal prolapse noted. Anal sphincter tone is normal with a resting score of 3 and squeeze score of 3, which is both normal by the dress code. Elevator NM muscle tone is normal. Modified Oxford grade 5. Sacral reflex of both bulbous cavernous and anal wing reflex are elevated bilaterally. This is the top Q study. The AA. Can I proceed now?
Yeah,
Yeah,
please
yeah.
go ahead.
Yes, yes.
Okay. The AA point, which is actually the point in the anterior vaginal wall, centimeter proximal to the external urethral meatus, corresponding to the location of the uretrovesical crease, is found to be -2. The normal range is between -3 to +3, ma'am. So this in our patient -2, and BA is the most distal portion of the upper part of the anterior vaginal wall, which is again -2. C corresponds to the most distal part of the cervix or the leading edge of the vaginal cuff in case of post-hysterectomy case. And in our case, the C corresponds to the cervix. AP is the point in the
There is some
midline.
background
There
disturbance,
is
I
some
think.
background noise, yes. Where
Uh,
from it is coming? I think it's the speakers, this thing, isn't it? There is some.
Komal, can you check?
May I request everyone
Yes, sir.
to be or Komalji, please
Yes, sir.
mute everyone
Okay, sir.
besides the teacher
And the students.
and the speaker.
Yes, sir. Sir, only co-host have given permission to talk. Otherwise, everyone
Yes.
is muted.
Yeah, please. Let's see how now, and just try to see from where the noise is coming,
Yeah.
so that we can try
Okay,
to
sir.
solve the issue.
Okay, sir.
Can I proceed, sir?
Yeah.
Please go ahead.
AP is the point in the midline of the posterior vaginal wall, which is 3 centimeter proximal to the level of hymen, and it is -3 in the patient. And BP is the most distal part in the posterior vaginal wall, which is -3. D will correspond to the location of the posterior fornix, where the uterosacral gets attached, and that corresponds to -4. GH is the genital hiatus, which is measured from the middle of the external urethral meatus to the posterior part of the hymen. And PB is the perineal body, which is measured from the posterior margin of the genital hiatus to the mid-anal opening, which is 3.5. And TVL is the total vaginal length, which is the only measurement which is taken after reducing the prolapse. And it is the greatest depth of the vagina after reducing it, which is 8 centimeters.
so what is the stage according to POPQ?
Stage 2, ma'am. The most distal portion of the prolapse is less than 1 centimeter proximal and but not more than 1 centimeter distal to the level of hymen.
Okay. Continue.
Summary: Mrs. X, a 24-year-old nulliparous, married for 2 years, who is a construction worker by occupation from a lower middle class by modified Kupasamy scale, came with complaints of something coming out of per vaginum for the past 1 year. There is history of heavy weight lifting as a part of her work for the past 5 years. There is no history of chronic cough, constipation, no history of urinary or fecal incontinence, no history of surgeries in the past. On general examination, her vitals were stable with a BMI of 20.3 kg per meter square. Per abdomen examination showed no abnormality. On vaginal examination, the external genitalia appears normal, but the cervix is seen protruding at the level of the introitus. No stress urinary incontinence is noted. No cystocele, rectocele, or enterocele is noted. Levator and muscle tone is normal. With a provisional diagnosis of a 24-year-old nulliparous woman with POPQ stage 2 prolapse.
Hello, Dr. Nivedita, before anyone starts your discussion, I just want to know from you, can you tell me, or do you know any other classification of prolapse of the uterus? And
yes,
accordingly, can you give me the diagnosis? Because POPQ is one of the classification. Accordingly, we can give the diagnosis. But there's some other classification also, so we can follow that and we can give our diagnosis. Do you know any other classification?
Baden-Walker classification.
Yeah. So according to that, according to that classification, what will be your diagnosis?
Grade 3.
This is the point I want to make to all of the students here who are joining, who have joined this program, that we should know the classifications, and accordingly we should have the diagnosis. It is not that universally POPQ is followed. Some of the teachers or some of the institutions may not be following POPQ. They might be following some other classification. So it depends on that. So you should be ready with all type of classifications of prolapse, because it is a very common topic, common disease which we see in our gynecological ward. So that is the message I want to give you. So we can continue with all the discussions.
So Dr. Ashok, it is really a great message. Dr. Bhavani and Dr. Nivedita, I would like to know from you, because most commonly used classification in our setting, everywhere in the busy OPD is SHOS classification. We do the POPQ later on, just pre-surgical and the post-surgical. I just want to know from you that as per the SHOS, which degree of prolapse it is? Cervix is coming up to the introitus, as per you.
3, ma'am.
How can it be 3?
SHOS.
SHOS
It is as
takes the
introduction.
consideration to the external os level in relation to ischial spine, right? Because external os situated normally at the level of ischial spine.
If I tell what is the SHOS classification, this is given in every book.
And that is everybody should know actually. POPQ is a quantification just to document your surgical outcomes at the end.
Okay, ma'am.
Tell
So
me
as
the
per-
landmark for this SOS classification. POQ is hymen. Then in case of SOS, what is the?
I already told it is the external os is situated normally at the level of ischial spines, right? If it is descending below the ischial spine but not yet reached up to the introitus, it is grade 1. If it is reaching up to the introitus, it is grade 2. When it is outside the introitus, this is grade 3. And when whole of the uterus is beyond the introitus, it is grade 4 or procedentia. You must know this classification, right? And the SHOS classify not only the level of the cervix, as per the classification of cystocele and antrocele is different. In antrocele, the lowest level of descent is up to the level of ischial spine, and cystocele exactly follow the cervical descent.
And you all have to remember this. Madam, I will add it here that we are talking here of cervical descent below the ischial spine. We never talk the term prolapse here. We talk of cervical descent, 1, 2, 3 like that. So you have to be very careful what words and what terms you are using and what classification you are using. So I request everyone to please be aware of all the other classification, Beden-Walker, Shaw's, Jeffcott, then Malpass. There's so many classifications are there, but at least you should know 2, 3 classification so that you are very well aware what is happening. Okay. Continue.
And one more thing, in your
I think
examination, you have done the examination only in the dorsal position, you know. In the prolapse case, it is not the dorsal position only. It is recommended that it should be either in the standing position as well or during the squatting position, and when the patient is performing the Valsalva's maneuver, you know, then only you can be sure about what exactly is the level of descent. Otherwise, you're going to miss.
Very true, and the position is very important while determining the amount of prolapse, or we can call it like this. The students must understand that these are deficiencies or weaknesses or the defects in the compartments. So nowadays we think in terms of compartments, and as Dr. Ashok Kumar said, the cervical descent is very important and is suggestive of the central compartment defect. Along with that, the prolapse of the anterior vaginal wall and posterior vaginal wall are also very important. And so my suggestion will be that you should learn at least 3 classification system. 1 is the Beden-Walker classification system, 2 is the Shaw's classification system,
Yes.
and 3 is the POPQs. So I think that you end up with POPQ so that you have a fair idea about the amount of correction to be needed in the respective compartmental defects. The examiners want to know which compartment defect primarily it is. And therefore, correction of the compartmental defect is better done with the POPQ staging. But the grading or the staging of the prolapse, as Dr. Ashok Kumar said, most of the examiners are well conversant with, and they want to hear these 2 classifications. That means the Beden-Walker and the Shaw's. Malpass and other things may not be easy to remember, but these two classifications, I think the students should know at the PG level.
In Malpass, I think only they should be able to differentiate whether it's a general prolapse or a UV prolapse, so that you can decide the surgeries. What
Correct.
kind of prolapse it is in nulliparous prolapse in most of the time? Is it general prolapse or UV prolapse?
UV prolapse, ma'am.
In your case, it is
nulliparous
not
prolapse.
vaginal prolapse. You know, it is only uterocervical descent, we call it, in nulliparous. And I just want to tell you something about the different classification which are being used. It is very important, you must understand. POPQ is in a quantification, which is basically for the documentation how much your surgery has improved the prolapse. You can quantify, inter-observer variation will not be there.
And
Then we go for the-
universalize. There was no classification which was so long, universally applicable to all geographical areas of the world. So POPQ was devised for that purpose. So I think that is it's a good way for that, for statistical purposes, for demonstration of the operative correction, or pinpoint which compartment requires how much of correction, etc., etc. But for all general purposes, I think these two classification systems are good enough.
See,
So
you should know the Shaw's classification, which actually tells you about the all degrees, what is there in the most clinically based classification in the BZ OPDs. And then when you talk about the Malpass classification, that is mostly for the etiological thing is there. It is in a primary, it is in a secondary, it is in acquired, it is in a congenital, right? So you should know it talks about the etiology, it does not talk about the degree of prolapse. So that is how you need to know the etiology. If you know the etiology, you can take care of the better. And then the nowadays era has come, then you should identify the site-specific defect, which is very, very important. You must understand. Of course, we are going to discuss that site-specific defects when you're having the second case.
Okay, I want to ask one thing, Nivedita and Kristen. You said in the differential diagnosis, cervical elongation, and it is nulliparous prolapse. How will we differentiate, and how we know that it is not cervical elongation, it is nulliparous prolapse?
A uterine sound can be used for the same, ma'am. Usually the infravaginal and the supravaginal part of the cervix will almost be equal. So we can use a uterine sound to measure the cervical length and again measure the infravaginal part of the cervix. So in case the infravaginal part is more than the supravaginal, we know that there is infravaginal elongation and vice versa.
Just clinically by your hand examination.
No, just Nivedita, tell me, in all the cases of prolapse, do you use the uterine sound while examining the patient in OPD or, for the evaluation before operation? Or you take some other method?
Deep fornices will be there, sir. In the cervix.
So tell us the clinical features which are suspicious of, or the suggestive of, not suspicious, suggestive of the elongation of the supravaginal part of the cervix or intervaginal part of the cervix.
Do you want to palpate something and see? The sounding is not all the time possible, no? So what else can be done? It will differentiate everything, whether it's there is a supravaginal elongation, infravaginal.
Okay, you can just enumerate in general, how do you differentiate whether it is in a simple cervical elongation or it is in a cervical descent or it is in a combination of both? Because these I have to understand before I want to decide managing this patient. You told in the cervical elongation isolated, there will be the portio vaginalis of the cervix is elongated. You will get a deep fornix on that, right?
Yes, ma'am.
And then when it is in a cervical descent, then you will get a shallow fornix where the posterior vaginalis to be the normal in the length, right? And then another test you can find out to look whether it is in a combination of both of this or not. Put your finger in the lateral fornix, ask the patient to cuff and see whether there is a sagging of the fornix while cuffing of the patient. If the fornix sags down when the cuffing is there, that indicates there is some defect or the weakness of the ligaments also. Right? You got understand, I think?
The students must be familiar with the concept of a measurement of the size of the uterus. If you find that the uterine size is normal by your digital bimanual examination, and in a case of prolapse, say nulliparous prolapse, then it reasonably rules out the supravaginal elongation of the cervix. Of course, you need to confirm it later with uterine sound and other things. But if you just see that the uterine size is normal, then comes the question of fornix, whether the fornix is deep or shallow. And lastly comes the confirmation by the. So these are the three basic things that you need to do to examine, in a particularly in a case of nulliparous prolapse.
Can you just tell me what is the ratio of the uterine length and the cervical length in a woman with the reproductive age group? What is the normal uterocervical length? It is 7.5 centimeters, right? Then what is the length of uterus and what is the length of cervix in toto, both portio vaginalis and the supravaginal? If you know that, then you will be very able to understand what Dr. Ashish had told about. So you have to look for the ratio. So normal ratio is 2:1. The uterus is twice in length as compared to the cervix, 5 centimeter and 2.5 centimeter. If you're finding that this is becoming almost equal or it is decreasing, in that case, you must understand there's a cervical elongation. And it is very well said by Dr. Ashish, if you get a uterus to be bigger, because in the portio vaginalis, we don't palpate the uterus is not included when you do the PV examination because you're putting your fingers either in the anterior fornix or the posterior fornix. It takes care of the measuring the supravaginal cervix as well as the uterus. But it is only cervical elongation, then the supravaginal elongation is not there, so you will get a almost normal size of the uterus. Other than when it is associated with some.
Yes, the ratio that Sarita was talking about keeps changing from birth. At birth, it is 1.1:1. Then it keeps changing to 1:2. Then finally, it assumes the adult ratio of 2:1. It's a very important thing to note. And also, whenever you see that you must have a fair idea about what a normal size uterus feels like. I mean, you have the only two fingers going through the fornices and palpating up to the fundus. And you must have an idea about the normal size of the uterus. Once you have done that, you have done half of the examination about the supravaginal part of the cervix is concerned. Now, whenever you find that there is some increase in the length of this thing, you have also with other findings like ultrasound and the uterine sounding, then you can differentiate between the supravaginal part elongation and the uterine part. So I think students can explain these things to the examiner during examination. These things are important, particularly in nulliparous prolapse. That's why we are discussing these at length here.
Okay. The next question, Nivedita, is you said inversion of the uterus. How do you differentiate whether it is the inversion uterus or prolapse?
Inversion, ma'am. So,
the epithelium will be visualized.
Inversion, ma'am. We'll not be able to introduce the uterine sound in case of inversion, ma'am.
Yes.
But incomplete inversion, you can.
No, first to do per speculum and you'll be able to see, you'll be able to differentiate.
You're not going to be able to see that a pinpoint os. You will get something is coming through the cervical os and you can put an sound all around. And the fornices are deep in inversion. But in your case, this differential diagnosis of inversion cannot come at all. Cannot come at all. It is in a nulliparous women. Chronic inversion cannot occur in a nulliparous women. Rather, you could have a cervical, this fundal polyp can be a differential diagnosis.
Yeah, very unusual in a nulliparous prolapse.
Impossible.
Otherwise, quite unusual. And also, you should always have an idea about the clinical look before putting in a uterine sound. I always keep saying
Yes.
the uterine sound is not always available everywhere. It is also an invasive procedure. Might as well induce infection in some cases. So better, I think you prefer to discuss all these issues or to describe all these issues without an uterine sound. It may come later on when the examiner insists on the confirmation of something like that. But do not, first of all, for the diagnosis purposes, you do not always need the uterine sound, isn't it? So that's an observation which you should note, and always stick to the clinical part. What your eyes are seeing, what your fingers are feeling, what are the sizes of the uterus, what are the other features, etc. So then only you will be able to successfully do that.
The next question is how to investigate. Start investigation. For this nulliparous
I think
prolapse.
before planning for the investigation, you should have something in the mind what you are going to do with this patient now. There are two issues with her. One, she has a cervical, I don't know your case as a cervical elongation or a cervical distance because your findings are not telling me exactly what it is. Then the second thing is she is in an nulliparous and anxious to have pregnancy as well. So you have to resolve these two issues, right? So you have to think what you are planning to do with this patient, because once you plan, then only you will investigate accordingly.
That's another issue, Sarita. You must have noted that the patient is married for 2 years and she's not complaining of subfertility or inability to conceive, isn't it? So
She's
I think
planning to pregnancy, she's mentioned about that.
yeah, but then 2 years is a quite some time, and I think that she hasn't been. You have to ask her how really willing to have a baby she is at the moment, isn't it? Otherwise, then she should have been presented with the complaint of subfertility, right? She hasn't. Her only complaint was there's something coming out her vagina. Maybe that she was associating this with the subfertility. Maybe it's possible, but then she's not presenting with the complaint. Anyhow, that doesn't stop you from investigations. You can always do the investigations, because after 1 year of marriage, if the lady fails to conceive or have difficulty in conceiving, then you are allowed to do the investigations. But complaint of the patient is important.
See, in this case, she has never used any contraception, right? And for 2 years, she's married and she's actively having the intercourse. So not becoming pregnant, one thing, it is an indirect indicator that she's
Should
suffered.
demand some investigation, should demand.
So in that case, you have to ask for that.
Yeah. There
Because
may be
whether
other
you want to investigate for infertility or not, if they are using the contraception, maybe the barrier method, maybe the withdrawal method, which is most commonly practiced, then you may just not investigate for infertility, right? And now in this case, when she's just having a cervix coming up to the introitus, how far you are going to think for the surgical management, how you're going to look for other things. So based upon that, you just tell me what you think about to plan the management for this patient.
So do you have any doubt about the provisional diagnosis or any other differential diagnosis? Investigations are basically directed towards the establishing a final or confirmed diagnosis, isn't it? So what are the investigations I would like to see in this case? Even if you temporarily forget about the subfertility, then what are the investigations that you are proposing for this particular case? Nivedita.
Routine investigation, sir. To begin with the complete blood count, HB was hemoglobin was 10.7 and with total counts of 7,980 and platelet of 3.1. And urine routine and urine culture were also done, which showed no growth in the patient.
Okay, so looking at the list of investigations, it seems to me that you are going for an operative solution of the problem, isn't it? Because most of these investigations are pre-operative investigations that we do routinely in all cases of operation. So in that case, I would like to ask you, how do you counsel this woman about the success of this operation, or what are the plans for the operation? How do you counsel the woman? This is important.
We'll counsel the patient regarding the various procedures available. And what are the other options, conservative managements available to
So
the
do you want to
patient?
ask her first what is her intention? That, depending on that, you have to plan for the surgeries, no?
I just first want you tell me your diagnosis is a cervical elongation or it is a cervical descent, because everything is going to be based upon that.
Cervical descent, ma'am.
So now here the cervical length is coming to be 5 centimeter, 2.5 centimeter posterior-vaginalis and 2.5 centimeter is your supravaginal. That becomes 5 centimeter. I don't think that the 5 centimeter length is a normal length for a woman. I want to be clear first. Is it in a cervical elongation or it is in a cervical descent?
Both are equal means what? And what happened in
yeah, 5 centimeter length, it is making me confused. So for that, I specifically asked for look for the sagging of the fornices. If sagging is there, it can be combined, you know. There is elongation, definitely. The 5 centimeter cervix is not a normal cervix. 2.5 centimeters posterior-vaginalis is not a normal length. She has an elongation of supravaginal and the posterior-vaginalis both. I feel it is a mixed type of things in your case. And then my management is going to be different, you know. So the first thing I'm thinking, it is a mixed type of condition, and then about the infertility, I think she has a subfertility for which she is not bothered at this level, but she will get bothered. So I will investigate this patient for the infertility, as well as now I have to think, am I going to do a surgery for that, or am I going to just strengthen the pelvic floor muscles? Because there may be the reason I'll just advise her the Kegel exercises with the biofeedback and all, the muscles becomes strong, then the cervix will go up, it won't bother her. Even this long cervix can be the cause for the infertility on her. Right? So you have to ask the history whether she was trying for the pregnancy or not. If she's not using contraception, she needs a workup for the infertility as well. And then she needs a management for this based upon that. Because if she wants to have the pregnancy, my management strategy may be different. Okay, you go ahead and tell me. Okay, go further, sir. You can continue, Dr. Ashish and Dr. Rajkumari.
No, but this infertility issue is important and you need to counsel. Counseling is extremely important. You see, you must be open to the patient, describing everything, that what are the pros and cons of any operative treatment, what is the important, because they have mixed ideas about the fertility, about the reproductive outcome, etc., etc. And also,
so we can ask the direct question now. Can you tell me an elongated cervix or the uterocervical descent can lead to infertility? If yes, then tell me why.
Yeah, you can ask. Yeah, that is possible.
Because if you can answer why, then you can plan the management.
There can be a mechanical difficulty, ma'am. There may be coital mechanical factor, coital difficulty, ma'am, due to the cervical descent or prolapse, or there can be any vaginal or cervical infection which can be a hostile for the sperm implantation, and there can be.
The most important part is the cervix is long. Cervix sperm has to travel a long distance. You know, second thing about the uterus is anteverted or retroverted. In your case, I don't know. I just missed that. If it is a retroverted, the retroverted itself is a cause for the infertility.
The cervix should be bathed in the posterior fornix where the semen is deposited. Then the ascent will be easier. Here, deposition
mention the direction of cervix also. It is forward or it is backward. That makes a sense in the infertility patient.
So we are discussing about the travel of the sperm, but then other issues like the pH issues of the vagina and the cervix, they assume extremely degree of importance, and therefore, so these are all also the coital difficulties that the student said is also important. So it's a multifactorial phenomenon that it leads to poor reproductive outcome. So I think everybody will agree, including the patient and the relatives, that it needs correction. And it needs correction. If it needs, the moment you reach the conclusion that it needs correction, the only option to reach to the point of satisfaction is a surgical correction, because there is no medicine or no exercise which will be able to restore the intravaginal positioning of the cervix, restore the pH of the vagina, and also other issues, the coital difficulties, etc. So you need to have a proper discussion on that. And here the importance of the cervical link comes very, very important, because the basic answer is whether we should go for the cervical amputation or not. And that is a two-way sword, because if the overzealous correction will cause reproductive failures, whereas if you do not correct it, if you undercorrect it, then there will be the problem persisting. And thirdly, the point is that you must also remember that this vaginal prolapse inside the vagina, that also causes other difficulties as well. And so I think that it's an overall counseling, with explaining everything to the patient and taking her consent and explaining about the surgical correction is extremely important.
Nivedita, you tell me simply, this patient has come to you, had done everything examination. You tell me what you will do with this patient. Do you want to do a surgery or you want to manage conservatively?
I would like to do a surgery, ma'am, given problem
Give me
of
the
infertility.
justification why you want to do the surgery.
Given that there is also a factor of infertility associated with it.
I'm more worried because she's infertility with the surgical intervention. You should justify you want to give a surgical option to her. Why you want to give a surgical option? See, I'm not telling you can't do the surgery. I'm just asking you need to justify, you know. So that depends how much she is being bothered with this second degree cervical descent. First thing. And second, you have to rule out other causes for her infertility. If everything is fine, you can blame this cervix for her infertility, and then you can think for the surgical intervention, right? Okay, now you decided to do the surgery. What surgery you will plan for? I'm not going to talk about the discussion about theoretical, what are the different types of surgery. You tell me for your patient which surgery you will select.
Sling surgeries, ma'am.
Okay, you selected the sling surgery. Can you tell me why you did not select the Father-Gill's operation? Just answer 1, 2, 3, 4. This is very important. You're right. You will select for the sling surgery, but why? Why not the Father-Gill's?
Or even Purandare's operation.
That is a type of sling.
You mean sling means
I'm just including all slings at once. Right now, we are expecting all slings. You tell me why did not choosing the Father-Gill's operation?
Father-Gill's operation, there may be post-operatively patients may have the cervical incompetence, cervical dystocia, and early pregnancy losses, ma'am.
See, you should be very specific. It itself can lead to infertility by causing cervical stenosis, by decreasing the length of the cervix, by altering the cervical mucus pattern because of the fibrosis. Then it can lead to early pregnancy losses. It can lead to this incompetent loss. Because of that, she can have the abortions. Then she can have the labor dystocias. So it has been its own problems. Okay?
That's why I call it a two-edged sword, na? Two-edged sword. This is a surgery is a two-edged sword. So you need to imprint upon the patient's mind that yes, that there is the best option perhaps will be going for the surgery.
And she does not have associated cystocele, rectocele, and androcele, you know. For that reason, I'm selecting the sling surgery, right? Now, among the sling surgery, now your favorite question, what are the different types of sling? Very easy question.
It can be anterior sling surgeries or posterior sling surgeries based on the site of support. Anterior sling surgery example is a Purandare, and posterior sling surgery the example is a Shirodkar and Kanna sling surgery.
Kanna is not posterior sling.
So
okay, can you tell the fixation of the sling and the Kanna sling?
Sorry, ma'am.
Fixation points in Kanna sling surgery?
Anterior superior iliac spine, ma'am.
Okay, and the anterior sling? Anterior sling is a Purandra's sling you said. No, what is the fixation point in anterior sling?
In which the two strips of rectus sheath is dissected, and the lateral end is being remains fixed, and the medial end is passed through the inguinal ring and the broad ligament, and is fixed to the anterior surface of the uterus, ma'am.
So it is original Dr. D.N. Purandra's sling. Can you tell me the modification which is done by V.N. Purandre and Praveen Mahatil? Because these are our Indian legions, no? We cannot forget them. What is the modification which is done by these two legions, Dr. V.N. Purandre?
And why were the modifications done?
And why the modification was required?
The Mercelin tape is used, ma'am.
Anything other? One, instead of the rectus sheath, the muslin tape is used. What is the other modification?
And
See, Dr. D.N. Purandre said the sling should be fixed on the anterior surface of the cervix. That is associated with the retroverted uterus and precipitation of androcele if it is not there. Then Dr. V.N. Purandre and Dr. Praveen Mahatil has modified, put the sling on the posterior surface of the cervix at the level of his stomach. You know, when you're doing this, then your outcome is better. And the muslin tape is being used. These are two modifications are being done. Okay, and then what is Sonawala's, before coming to the Sonawala sling, I think this posterior sling is your Shirotkar sling. And why the Sonawala's modification was required?
in Shirotkar, there is an increased injury to the, there is a chance of injury to the sigmoid colon on the left side. And
this section is very difficult. Okay, and then why what is Sonawala's sling?
A muslin tape is used, ma'am, in Sonawala's, and it is attached to the uterosacral.
In Shirotkar also the muslin tape is being used.
It is attached to the uterosacral posteriorly, and the ends are carried from the right side and are fixed anteriorly to the anterior longitudinal ligament in front of the sacral promontory.
So Sonawala's sling is unilateral right-sided sling only. It is in a posterior sling, right?
Which is what is Virkut's sling surgery?
This is a composite sling surgery, ma'am, in which right-sided Purandre and right-sided Shirotkar and left-sided Purandre is done, ma'am.
And along with that, because the uterus becomes tilted on that way, so you have to do something else. What is that something else to make the uterus Siddha again?
Because there will be pull on the right side, no?
So you need to do a plication of the uterosacral ligament on the site where you're doing the anterior attachment. So that will make the uterus again in the normal
Left
position.
uterosacral plication should be done. Okay. There is one more, no? Joshi sling surgery. I think rarely used.
Joshi, ma'am.
Yeah, what is Joshi? It is not rarely used. Nowadays, laparoscopically, they are doing the same thing and getting the very good results.
We first with the urinary problems also.
Yeah.
It's the point of attachment is the pectineal ligament, ma'am. On the
Yes.
both.
So it is an extra peritoneal through the retropubic space you are doing. So chances of injury and the bleeding is more. And it is easier to perform the laparoscopy than the laparotomy way. So that is again an option. And then again, if it is associated SUI is there, you can do the simultaneous birth corpus suspension with that.
Okay.
Okay. So we have the time for this case, then we can discuss further or we can take the next case. We have the time, I think 15 minutes time for this case. So are you ready to give the more viva for another 15 minutes?
Yes,
then we can
yes.
discuss and
Yes, ma'am, we can take for some more time, maybe around 5-10 minutes for this case.
So we are just going to talk about certain like common question. What are the disadvantages? You have not told me about the types of sling. One you told about the anterior, posterior, lateral, or the composite. Then other type is open and close. What is that open and close you mean by?
Shirotkar is the example of a closed sling surgery, ma'am.
The enclosed sling surgeries, the loop is closed from both the sides, ma'am. And for example, Shirodkar and Purandir and Joshi or the closed sling surgeries, and in open sling surgeries, the one end of the loop remains free, ma'am. Example of Vidbut and Sonowala and Khanna, ma'am.
Okay.
Advantage,
Then what do you mean by
disadvantage,
dynamic and non-dynamic slings?
It based on the supports, ma'am. The supports the supports are static and that is a fixed point. Example, sacral promontory or anterior superior iliac spine. It is they are called as static. And example, Shirodkar, Khanna, and
Okay. Can you tell me who is the legion from India who has given this beautiful classification of slings? This is Dr. Ajit Verkut from Mumbai. Okay, and it is a recent classification. Okay, now we are going to go on a more theoretical thing. Can you tell me the disadvantages of Purandir sling surgeries?
Dam has told you already.
Yeah, I already told earlier. What are the disadvantages of it is very easy, you know, easy to perform is an advantage. So what is the disadvantage?
Uterus is retroverted or introverted, just tell no.
Hello, are you muted or you're not able to answer? If you're not able to answer, we will answer because there are 169 participants viewing and which are they are hoping for the answers over here.
Yeah, and I think also we have to wind up early because we have a next case also pending.
Yeah. And if those who are the viewers, they can also write on the chat box if you know the answers, you know, then your active participation will be reflected over here. You're writing on the chat box, we can see if you have some questions and also you can write on the chat box.
The areas of study, I think we need to specify to them because nulliparous prolapse, I'm willing to give them a little bit of extra time because that's an important issue compared to the other type of prolapse, and therefore they should know exactly which extent they should study.
Then Dr. Ashish, I think it will be better we should start answering.
Yeah.
So in that, I'm just going to the disadvantage of the Purandir sling. It makes the uterus retroverted. That can be one of the cause for the infertility. If there's an androcele, then it can precipitate onset of androcele. Then if you're planning to go for the cesarean section, the vaginal delivery can be allowed. But if you do a cesarean section, your sling is going to be lost. It is cut. Then the recurrence of the prolapse will be there.
That is why the modifications have come and they have already discussed. Next.
Then what is the problem with it is very important nowadays we are preferring the Shirodkar sling because it is very static and it's a long lasting. It does not have the disadvantages like the Purandir surgery. Can you tell me the major complication associated with the Shirodkar apart from in Shirodkar and apart from the injury to the sigmoid or the ureteric injury? During surgery, it is very important which level you are fixing, how to identify that particular level, which vessels are going to injured when you're doing this.
Section and placement of the sling is also quite difficult. So,
Dr. Nivedita and Dr. Bhavani, you know, you need to be little bit more. Don't feel blank, you know, there's nothing wrong with you. You're very well presented the history and done the examination part very nicely.
I think maybe they're not connected because they're
not visible, they're not connected.
I think, ma'am, they have lost their connection.
Okay, a quick sum up of the different types of sling that they need to study, and then you wind up this case.
Yes, sir.
Also, they should know the different Shirodkar's modification of further gills also.
Yeah.
In case we are not well versed with the abdominal sling.
Yes.
We might have to do vaginal sling surgeries like Shirodkar's or further gills.
Madam, I think everybody is because they are got disconnected and the next participant are not there. But for 164 participant, we can answer this.
Next
so for
participant.
the Surendra, I had told, then you come for the Shirodkar. The middle sacral veins are the highly area where you can injure, even the hypoglycemic nerve for the like reckless surgeon. So anterior longitudinal ligament at the level of L5, S1 and S1, S2 is there, never go below that. That is the point of fixation. And then you need a Shirotka's needle on when you're doing the Shirotka's surgery. But nowadays we have the long curved artery forceps which can also be used, and you fix the mesh on the posterior surface of the cervix in Shirotka's. Then you make a psoas loop if you are doing on the both the side, that is on the left side. And the Khanna sling is little easier, they say, but I have never done, and it is not practiced also. So with that, the Virkur sling is a very commonly used practice nowadays. And the laparoscopy, I think Dr. Neeta Vati is there, who is doing lots of laparoscopic slings for this patient. I just want to know, I think they are not connected. If there's an associated cystocele, and that also needs correction, then what should be your step? So for that, it is said you do a cystocele repair from below first, and you can place your tape from below also, and then you do the sling surgery.
Yes, to
So
need the
need
extent of the surgery and also to fix the sling.
Yeah. So these are, and then if she is an infertility, it's very important before doing the surgery, you investigate thoroughly that she is not having other infertility factor, the reason for that. And then again, because she's an infertility, simultaneous, you can do a chromoperturbation test for this patient to look for the tubal patency. Otherwise, you will need an HSG or the laparoscopy in the future. So do a tubal patency. There is again a medical legal importance. She might be having the non-patent tube beforehand, and then your surgery can be blamed for that. After that, they develop the tubal block. So with that, from my side, I think the nulliparous prolapse is finished. There are so many other things to discuss, but we have then another case, Dr. Ashish, I feel.
I think the important point to differentiate how much they should say about in this particular case, since the patient doesn't have a presenting complaint of subfertility. So that's I think that's a point of concern for the surgeon also, and you should explain that we need to investigate about other factors of subfertility, because if they're not presenting with the symptom, they will not be very enthusiastic about the investigation. It's expensive also.
And I want to make one thing, sir. They always tell, and sonography in all cases here, they miss the sonography. This is again very important, a transabdominal, transvaginal sonography to be done beforehand. And then you should do a pap smear to rule out malignancy or any other thing. Whenever you're planning any conservative surgery, you have to rule out the malignancy. And for that, you have to do a proper workup for these patients.
That's why what are the investigations they're going to do? And most of their investigations were directed towards the operative correction, and none of these issues were addressed. So I think you need to add all these investigations to your investigations list before going into the preoperative investigations.
So I just want to add, whenever you're doing in a prolapse case, your aim is to find out what is the etiology, then what is the degree of prolapse, is there any associated gynecological condition, is there which is going to change your intervention, is there any associated medical disorder which can again change your decision, and then what is the tone of the muscles. You need to look into those things, and based upon, and then associated complaints in the form of cystocele, antrocele, and ractocele. And based upon these 7 to 8 factors only, you can decide what to do, when to do, and what not to do is very important.
There they have presented an USG report, which is missing over here is the length of the cervix. I believe it is not there. And so I think that there was a TVS not done. TVS is extremely essential in this
So this
case.
USG finding is a controversial finding. The cervical length is 5 centimeter. The total uterine length is 7.3 centimeter. I perceive the uterus is very small to be only 2.5 centimeters.
No, where is the cervical length they have mentioned in the USG report?
So is it an infantile uterus then? And the width of the uterus, if I look at 5.4 and 6.1, it is a wider size of the uterus.
You mean you have calculated from the length of the uterus and then the clinical finding of the cervix, right? There is length of the cervix can be easily ascertained with the help of a TVS probe.
Yes, it is very important. You have to measure the length of this ultrasound finding is not matching with their uterus cervical length.
Correct.
So this is how the examiner can make out whether it is in a made case or it is an actual case, right?
No, the case is actual.
It happens that in the exams, the students just modify the things and then they are getting caught on that way. So you just write what actually you are getting when you're doing the examination, and a student manipulate it.
Ashish
So
sir, can you
students,
go to the second case? Sir?
yeah. I think Hafizur, I will close with the comment that you see the students' involvement with the cases at the PG level is so very important to look at the case in a more comprehensive manner, in a more thought-provoking manner, how to find out the etiology, how to find out the diagnostic modalities, and then going for a definitive treatment aiming towards correction. So involvement with the case of the PGs is more important. Thank you, and we'll proceed to the next case.
Yes, sir.
So thank you, Dr. Nivedita and Dr. Bhavani. You did well.
They have presented well.
Yeah.
Very good.
Yeah. Please stop sharing screen, Nivedita.
Yes, sir.
And for the second case, it is the College of Medicine and JNM Hospital, Kalani. The students, Dr. Sharna Nandi and Dr. Sanjit Patel. Dr. Sharna and Dr. Sanjit, can you start sharing your screen?
Yes, sir.
And I'd like to request the faculties to take over. Dr. B.R. Sharma sir is there because I have not seen sir. Dr. B.R. Sharma? Sir, are you there? I'd like to request all the faculties to take over, please. Please start, sir.
Dr. B.R. Sharma is from Mandi, isn't it?
Yes, sir. Yes, sir.
He
Sir
is
is
there?
from Mandi, Sri Lal Bahadur Shastri. He is supposed to be there. He had a confirmation from me even today morning also, sir.
Okay.
He had some network issues at the beginning. So please introduce yourself and start presenting. Make it a slideshow. Shona, can you make it slideshow?
Yes, sir. It is already on slideshow. Is it visible, sir?
No, it is not showing in the shared screen.
You simple press F5 in your laptop. That can no. Can you press F5? F5. That also makes slideshow.
Sir, just a minute, sir. Actually, our laptop does not have that function, sir.
Okay. Then you press on the slideshow button.
There is a
Yes,
button
sir,
on
in our
slideshow.
laptop.
Go to the slideshow.
Sir, is it visible now?
No, it is not yet visible.
It is visible, but it's not in slideshow mode. No.
It will come, I think.
You make it full screen. No, that's what we know. You can. There is a slideshow option is there when you see the different modes of the presentation.
Yes, sir. Is it now?
Not
No.
yet. You did it other day. It is the same laptop.
There's some delay in the
Yes, sir.
transfer.
This is the same laptop.
Sir, I think they can go start presenting like this. If you
Yeah,
can take someone's help if you can do, or you can go like this.
Go ahead. Go ahead with this.
Go to the first slide.
I'm helping her. It is very easy. You can see the slideshow option there. Look at
Yes,
the right
ma'am. Yes,
side
ma'am.
of the. Yes, you got it. Just click it.
Yes, ma'am. Yes, ma'am. Is it now visible?
No.
They have been clicking it, but that's not happening.
I think they can present if slide is moving so like this. It's quite visible.
Maybe there are two screens, split screens. If you have to close one. If your laptop has that option, sometimes there will be two screens.
In above also, you can see in the bar that the slideshow option is visible.
ये तो पूरा ही चला
Okay.
Share
Share it
again.
again.
In upper part also in the bar, you can see that the slideshow option is mentioned.
Dr. Munideep, are you there with the students or you are some other?
I saw Saris logged in.
Yeah, Dr. Munideep, I can see. Munideep is muted actually. Munideep, please unmute yourself.
Yeah. I think Saris. Yes. Now you can unmute yourself, Manideep.
Yeah. Yeah, Munideep, try and correct this because if it is not possible, it's not happening, then we'll go with the slide presentation. Yes. Now it's done.
Is it now?
Yeah,
It's
yeah,
okay.
very nice.
Yeah, perfect. Please go ahead. Go ahead.
Okay.
Please start.
Yeah, Can we start, sir?
Yeah.
A very good afternoon, respected teachers and mentors. This is Dr. Sanjot Patil and Dr. Shona Nandi from College of Medicine and JNM Hospital. Under the guidance of Dr. Professor Manideep Pal sir, we are presenting the case of perimenopausal pelvic organ prolapse. A 45-year-old lady, Mrs. KS, homemaker, Hindu by religion, having a non-consanguineous marriage, educated up to 5th standard, resident of Horingata, Noida district, West Bengal, attended OPD on 31st of January 2023, with chief complaint of something coming out per vaginum since 1 year.
Okay.
Patient was apparently all right 1 year back when she started noticing a bulge descending per vaginum, gradually increase in size, but were not visible outside the vaginum till date. But now it bulges through the introitus even at rest, especially while straining during defecation, lifting heavy objects, or standing for prolonged period of time. This was associated with dragging sensation in the perineal region. She was having difficulty in performing her day-to-day activities. She also complained about backache, which was on and off since last 6 months, especially during the end of the day, which relieved on rest. Patient gave the history of chronic cough since COVID-19 infection happening last year. There is no history of increased frequency, difficulty, or burning sensation or pain during micturition. No history of dribbling of urine during occasional coughing, straining, or lifting any heavy objects. No history of foul smelling vaginal discharge. No history of fever in the recent past. No history of constipation, incomplete defecation requiring straining, or any fecal incontinence. Now coming to the menstrual history, patient attended menarche at 13 years of age. She had regular menstrual cycle where bleeding lasting for 4 to 5 days every 28 days. The cycles were mildly painful and moderate flow, not associated with any clots, no associated with any foul smelling discharge during menstruation. Coming to the obstetrical history, patient is having parity 3, having 3 living issue. All of her pregnancy, the 2 of her pregnancy were home normal vaginal deliveries conducted by DAI. They were the pregnancy events, labor events, and puerperal or were uneventful. And baby cried immediately after birth. Immunization was given as per national immunization schedule. And the last childbirth was around 1908, uneventful, and that was normal vaginal delivery happening at the hospital. That was a female child with normal immunization was given. She was married since 30 years at the age of 15 years, last child but 25 years back. And as we can see from the chart, the spacing between children was 2 to 3 years. There is no history of contraceptive use or any sterilization operation. Past medical history, patient is a known case of hypertension since last 5 years, and she is on tablet amlodipine 5 mg OD. Patient has a history of COVID-19 infection last year, which associated with severe cough and chest infection. So she is still having on and off cough episodes since then. There is no history of bronchial asthma, chronic constipation, diabetes mellitus, tuberculosis, or any other medical condition. And also there is no history of blood transfusion or any other drug allergies. Coming to the past surgical history, patient is not having any hospitalization or any surgical history. There is no history of diabetes mellitus, hypertension, tuberculosis, or any pelvic organ prolapse or any connective tissue disorder in the family. In personal history, patient does not have any substance abuse history or no history of allergies to any known substances. Patient consumes a non-vegetarian diet. Patient belongs to upper lower social economical status according to the modified Kupaswamy classification, where she has studied up to 5th standard. Her husband is a semi-skilled worker and the monthly income is 15,000 per month.
Now we come to the general examination. The patient was examined after
1 minute. Swarna, actually our co-examiner Sarita loves to go for the crossing once segmentally. That means after the history part is over, because we are all aging and tend to forget things. So I think history, we can have some discussion before we go into the examination. And Sarita, I would like to begin the discussion with a few of the findings. Next slide, please. Go to the next slide.
Certain basic questions we can continue with that,
No, I'm
How
just
does the-
I'll just say that the lady who has been delivering a child almost at regular intervals of 1 year suddenly stopped conceiving after 25 years and without any contraception, without any sterilization operation. That's quite unusual. Anyhow, so that's what happens in our country because there is no family planning measures have been taken in this particular case. COVID-19 infection has been associated with the chronic cough. And so that was a confounding factor in this case, which may be the aggravating factor for the prolapse. Next slide, please. I'll just give it to you, Sarita, with the for your comments on the history part. Next slide. These are all okay. Yeah, menstrual history, and I find that this is obstetric history is okay also.
Sir, I had lots of comment on the obstetric history, the way it is being written in a case of
Okay,
prolapse.
okay. Tell us.
I just want to know labor events uneventful. You tell me for what are the labor events you are bothered about in the case of prolapse uterus in a perimenopausal women.
Ma'am, any history of prolonged labor or anything which actually she need to strain more and that might have weakened her pelvic muscles.
That's fine. I just want to know
Prolonged or
if you are
obstructed.
taking a UG teaching, because we are giving you the certificate of teaching experience as well when you do that PG. So you tell me if you have to teach about what are the labor events can precipitate or the etiological factor for the prolapse uterus, just enumerate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We classify in a mismanaged first stage, we classify the mismanaged second stage, mismanaged third stage. So what is the mismanaged first stage, which are the mismanaged second stage? Because that by that only we can reduce the incidence and the prevalence of prolapse in our country. So what are the events in the first stage of labor which can be responsible for having the prolapse in the future? If you can't, then I can just answer premature bearing down, excessive use of the oxytocin, and right?
Yeah, only that.
And just pushing the fundus from above, which is being done by the thigh, and irritating the uterus, which is done by thighs. That is a mismanaged first stage. And of course, prolonged first stage is one thing. Then second stage, mismanagement.
Delivering before the full dilatation.
Again, it is the first stage. No? So I asking her to bear down and pushing when the cervix is not fully dilated. Apart from that,
Instrumentations.
Unnecessary use of the instrumentation. Not indicated, you do it, but non-indicated, don't use it.
It is unusual in a home vaginal delivery.
Then failure to give episiotomy when it is needed. See, we say don't give, but it's not failure to give episiotomy right in the time. Okay, then mismanaged third stage of labor.
And premature delivering of placenta, which can cause the inversion of uterus. So the chronic inversion can also.
That
And
cannot
not
lead
giving
to
proper
prolapse.
support to the uterus while delivering the placenta.
Support at the time of second stage of labor is very important. So you should use a proper method of support. Mismanaged third stage is not waiting for separation of the placenta and asking to bearing down. Right? And then failure to repair the episiotomy in a proper way in the layers. If there is a perineal tear, you are missing that perineal tear and you're not repairing it. It happens, perineal body is damaged. Can you tell me what are the 3 factors which actually during the labor is the cause for the prolapse? You told it lead to weakness of the muscles. Which muscle? Perineal muscles. What are the perineal muscles?
Ma'am, kindly repeat the first question, please.
I'm just asking what are the factors during the labor actual which leads to prolapse? One you told is a muscle defects, muscle weakness, and which muscle I'm asking to you? It is not perineal muscle, it is mostly the levator ani muscle, which is forming the level 3 support, which is important for you. Then nerve injuries.
Nerve injuries.
And then stretching of the ligament of the fascia and tear and wear of the facial tissues. which are forming the supports. So you must understand these things, right? Then you have mentioned the uneventful purpurium. Can you tell me what is the purpureal event which can be responsible for prolapse of the uterus? Because you want to prevent, prolapse. So if you know what least, then only you can advise the women so she cannot have the prolapse. Tell me what is the uneventful purpurium? What are the things you should think about in the purpurium which can be the etiology for the prolapse? So failure to perform the pelvic floor exercises and 3 sets of exercises. Strengthening of the abdominal muscle, strengthening of the back muscle, and strengthening of the pelvic floor muscle. We have to advise the women if they fail to perform that pelvic floor exercises. Then early resumptions of the activity, poor nutrition during the purpurium, persistence of anemia during the purpurium. Okay, so you have to ask about those things. Or starting work early. And homemaker doesn't mean she's taking the rest. In home also she does lots of work over there. So you have to give an advice for those things, right? Okay.
Sarita, we should move faster because, there are a lot of discussions pending in this case.
Yeah, we'll go ahead. Sir, it's a problem with me, I can't go if I finish of the earlier things.
Okay.
Okay, go ahead. Go ahead.
Yes, in the past, in the dietetic history, I think you need to go to the next slide, please. Where is the nutritional and dietetic history? Yes. Patient consumes non-vegetarian diet. Do you think it is enough for the nutritional dietetic history or need some more details?
So you need to learn from the previous case. They have very well presented the nutrition and the dietary history.
Yeah, even if that much of this thing is not necessary, you have to ensure that the patient has a balanced diet. Non-veg or non-veg doesn't matter, but then really 6 proximate principles of food must be there, and signs of vitamin deficiency and calorie deficiency and protein deficiency, particularly in cases of anemia, in cases of prolapse, are very important. So I think you can elaborate on this nutritional and dietetic history to a slightly more relevant details.
I want to have an answer. You mentioned there's no history of past surgeries. What are the surgeries which can be responsible for your prolapse uterus?
Any past pelvic surgery which is done during.
Any doesn't mean anything. I just want you to enumerate few surgeries, the gynecological surgery and the non-gynecological surgery, which can be responsible for prolapse uterus. Some gynec surgery, can you tell me?
If patient is having the history of congenital cervical elongation, any surgery done for that?
Congenital elongation does not lead to prolapse. It is multiple DNC or the dilatation and evacuation where pulling the cervix. That can be the responsible thing. And then the non-gynecological surgery. And then if you're doing the recurrence and then antrocele and all, there's a specific things for that. After the post-surgical valve prolapse, there are a lot many things. But I'm talking about some of the non-gynecological surgery which can be responsible for prolapse of the uterus.
And previous LSCs can also cause the adhesions of the bladder, and while performing the actual pelvic surgeries in the case for this, the bladder.
You raised a very bad question over here. Can you tell me whether the cesarean section is protective, no effect, or it can predispose?
No effect.
Elective cesarean section does not have any effect. Cesarean section is not at all protective. But if you are doing the second stage cesarean section, then itself the prolonged labor and the indication for cesarean section is responsible for your prolapse. Okay, amongst the non-gynec surgery, if you're doing the pelvic exantry, whenever the surgeries are done and the neurological damage is there to the pelvic nerves, okay, then it can lead to prolapse of the uterus. It's like an exantration or the rectal surgeries where you're going to deep in the dissection in the pelvis. Okay, the pelvic innervation can be affected. Hernia does not cause prolapse of the uterus. Right? Go ahead. And
will
again,
be
you have
general.
not mentioned the examination. Okay, you're coming to the pelvic examination later on. Come on.
Patient was examined after obtaining proper informed consent from the patient, and patient is alert, conscious, cooperative, moderately built, and well nourished. Her height was 152 centimeter, weight 52 kg, BMI coming down to 22.5 kg per meter square, temperature 96.5 degree Fahrenheit, afebrile.
I think to
Respiratory
save
rate
the
was
time, your general examination part is all okay. We can skip Dr. Ashish. Is it okay?
What?
But can skip the general examination, finding it appears to be all normal.
Okay. And we have enough discussion in the last case.
That's true, sir.
Yeah.
Respiratory system, bilateral vesicular breath sounds were there all around the lung parenchyma. No adventitious sounds was heard. For cardiovascular system, S1, S2 audible. No murmur or added sounds are heard. Central nervous system, no neurological deficit noted. Specifically, all the peripheral, central, and sacral nervous plexus was also has been done, which has been discussed later. And GIT, no hepatosplenomegaly, and IPS was there.
IPS, matlab? What do you mean by IPS?
Intestinal peristaltic sounds, bowel sounds are heard.
So don't make it complicated, use the standard abbreviation.
Yes.
And then GIT, no hepatosplenomegaly, is it enough? You should rather
There
tell the
is no-
per abdomen. You're going to talk in a per abdomen exemption separately.
Yes, ma'am.
So the GI is not written separately. You should write the per abdomen. Tell the per abdomen finally.
There is examination of breast. On inspection, bilateral breast is symmetrical, no skin changes, all local swelling noted. No lump was palpated, bilateral breasts are non-tender, no axillary or supraclavicular lymph node can be palpated.
Why the breast
On-
examination is important? You have
Ma'am,
done it is very good. You have done the breast examination mentioned over here. I just want to have a point why the breast examination important in every patient attending the gynecological OPD.
Just in case there is a carcinoma and
So it is an opportunity to diagnose and breast cancer in early stage. That's good. Okay, go ahead.
Not only cancers, any benign breast diseases, lumps, etc., everything can be diagnosed.
yes. On inspection, abdomen is scaphoid in shape, skin is healthy, no scar noted, umbilicus midline and inverted, all quadrants moving equally with respiration, and no engorged veins or sinuses are noted. No cuff impulse noted. On palpation, for superficial palpation, there was no localized rise of temperature. Abdomen was non-tender, no localized lump was there. Hernia orifices are intact. On
Again,
deep
hernial
palpation,
orifices make it that and hernia sites are normal.
hernial sites, ma'am. Yes, ma'am. Hernial sites are normal. On deep palpation, there is no organomegaly is noted. On percussion, tympanic note is heard all over the abdomen. There is no free fluid in abdomen. On auscultation, normal bowel sounds were heard. For vaginal examination, patient is examined in dorsal position with knees and thighs flexed with bladder comfortably full. On inspection and perspeculum examination of vulva and vagina, vulva appears normal. Vaginal introitus is widened. A bulge is seen protruding through the introitus, which is well visible on cuffing. Vaginal mucosa is pale pink in color. No mucosal thickening, pigmentation, or decubitus ulcer is noted. Rugosities are absent in anterior vaginal wall. No old perineal tear noted. External urethral meatus appears to be normal. No leakage of urine is seen on cuffing. On vaginal digital examination, anteriorly cystocele and second degree of uterine prolapse is noted. Getting above the fundus was absent. No rectocele or enterocele found posteriorly. Support test, no paravaginal defect. This is our POPQ scoring. For AA, we have found it's +2, BA +4, C 0, genital hiatus is 4, perineal body 2, and total vaginal length being 6. AP is coming to -3, BP -3, and D -4. For level 1, it is stage 2. Level 2A is stage 4. Level and B stage 0. Level 3, no stress urinary incontinence is there. Perineal body tone is normal. This is a graphical representation by Paul Weeks that we can see here. Bimanual examination is done. Uterus is retroverted, normal in size, smooth, mobile, and non-tender. Cervix is normal. No adnexal mass was palpable. On per rectal examination, skin creases around the external anal sphincter is normal. No hemorrhoids or rectal prolapse noted. Rectal mucosa appears to be healthy. Levator ani tone is good. Modified Oxford grade 4. Resting tone 3 for dress code. And squeeze pressure was 3. Sacral reflexes are done. And bulbocavernous reflex is good there. Anal wing reflex is also there. To summarize the case, it is Mrs. K.S., a 45-year-old para 3 perimenopausal lady from a low socioeconomic status, complained of something coming down her vagina since 1 year with no associated urinary symptoms at present. All 3 of her normal vaginal deliveries were uneventful. History of COVID-19 infection last year. There is no history of constipation, heavy weightlifting, urinary or fecal incontinence. On general examination, her weight is 52 kg, height 152 centimeter, BMI 22.5 kg per meter square. Hypertensive, but presently controlled with medication. Per abdomen examination shows no abnormality. On vaginal examination, vulva appears normal. Introitus is widened and there is a mass of approx 2.2 into 2 centimeter protruding through introitus, which bulges further with cuff. POPQ stage 2 uterine descent, stage 4 anterior vaginal wall prolapse, that is central cystoscopy. Posterior vaginal wall is unremarkable. Vaginal rugosity absent anteriorly. There was no decubitus ulcer or pigmentation. On straining or cuffing, there is no leakage of urine per urethra. Coming down to the provisional diagnosis, it is a case of a 45-year-old perimenopausal female, para 3, with uterovaginal prolapse, POPQ stage 2 uterine descent, stage 4 anterior vaginal wall prolapse, central cystoscopy.
Can I just see your POPQ grade with the level of cervix?
Ma'am, it's a 0.
Okay. And the slide later on? Just show me the slide thereafter. Okay. So Dr. Ashish, you can proceed. I think I asked so many questions.
Go to the previous slide. Before this. Before POPQ. Yes, I think. Yes.
You have mentioned only as bulge there. You should mention what is it, the leading portion or the prominent prolapse, what we say. I think she has mentioned only bulge. Is it a cervix?
No, ma'am.
Anywhere about cervix, I think.
No.
I think you
It
need
was
to
actually-
go back. Your findings written is not right. Go back.
Go back. Yes, that's what I wanted to say. Yes.
Yes, this is important. Anterior
first one.
cystocele and second degree of uterine prolapse. What do you mean by second degree of uterine prolapse if your C is at 0?
Ma'am, C is at hymen, and this is by second degree of uterine prolapse. We want to say that by Shaw's classification, it's not out of the introitus yet.
So the cervical descent is there as per the Shaw's classification, you mean to say?
Yes, ma'am. Cervical descent is there.
So there, when the POPQ and the Shaw's differ, because the point is hymen and the point of ischial spines.
Ischial spine, yes.
Ischial spines and the hymen,
Sorry.
these are the two different things,
Yes.
right?
Yes.
Now this getting above the fundus, I couldn't understand that. Getting above the fundus is absent means what? Fundus is absent? Or you mean to say that you can't get above the fundus, right?
Yes,
can't
yes.
get
Or I think third degree, if at all you're seeing it as a third degree,
Yeah.
when you want to differentiate from fourth, then only you need to do that. When
Yes.
it's only at second degree,
Okay.
you can't do also.
And what is
Yes,
a
sir.
support test? What do you do in
Sir?
support test? You have written support test, no paravaginal defect.
Sir, we open a sponge holding forceps and we put it in the lateral cornices and then ask the patient to cuff. And if there is a paravaginal, The paravaginal defects will not appear only central. If it's central defect, it will appear. And if it is paravaginal defect, if we give on one side, we give support, then there is on the other side, the defect will come down.
Okay, we generally do it with the help of a speculum, and the anterior and posterior vaginal walls are stretched. And then after coughing, if there is a bulge in the lateral vaginal wall, we come to this kind of, but sponge holding forceps, I'm not sure about this.
So this test is very well indicated how to test for the prolapse. I think they all are reading the Vyam Mala for the case discussion. It is very well described on that book. Anyway, I just want to know, you have mentioned anterior cystocele. Do you think this is some posterior cystocele?
No.
So you should rather
No.
tell it is an vaginal uterovaginal prolapse, you know, with the anterior vaginal wall involved only. Okay. And no rectocele or enterocele found post. This is the way which is written is not okay. Actually, we write that there's a cervical descent which is of 2nd degree. There's a cystocele which is 4th degree cystocele. I don't know about the POPQ, but it's the 3rd degree is the maximum cystocele. And there's no rectocele, no enterocele, and no rectocele. This is how it's in a better written, right?
How did you examine for enterocele? Could you just elaborate?
So we took a speculum and we just pushed the bulge of the anterior compartment inside the vagina, and then we asked the patient to. We also took another speculum and obliterated the posterior wall, and then slowly we gradually we tried to descend the speculum and ask the patient to strain. If there is an enterocele, it will be seen as a bulge coming from posteriorly.
Okay. So do you need to confirm it with the rectal examination?
Yes, sir.
Okay.
I think you should be very clear. It is called as a T-Linde test, where you use the 2 speculum. One speculum is retracting the cervix and the anterior vaginal wall, and the posterior speculum will gradually slide. You slide
Gradually
the
taking
posterior
it out.
speculum, and then after first bulge, you see a groove, and then you see the second bulge.
And also some changes over the rugosities of the posterior vaginal wall.
Yes.
And so now you move to the next slide, please. Yes, here is the contrast that Sarita was talking about. And I think that this POPQ graphics that is good enough. The AP and BP, they are, how much they are? AP and BP? -3.
So it is posteriorly at
-3, okay. So where do you think essentially the defect is? The main purpose of doing all this exercise is that. Where is the main defect?
The defect is in the anterior vaginal walls.
Anterior vaginal wall. And also, this, is there any defect in the main uterine axis or the uterus in the cervix? Is there any cervical descent? See, you said
Yes,
0,
yes,
isn't it?
Yes.
So
There is a cervical descent.
that is according to Shaw's classification, it hasn't crossed the hymen, but according to it has crossed the this thing, ischial spine, but it is the main defect is in the. Do you think that this anterior vaginal defect has dragged the cervix forward, or there is a primary descent of the cervix and then which has dragged the anterior vaginal wall? What is your idea? Now you have to plan about the repair, right?
So it is basically a uterovaginal defect.
Uterovaginal defect. And the uterus, you said retroverted. Did you say that?
Yes.
Okay. So with no defect in the posterior vaginal wall, virtually no defect in the posterior vaginal wall, and with the minimal descent of the cervix, and predominantly anterior vaginal wall defect is there. So what do you now, how do you propose to investigate, and what treatment will you propose now?
So before that, can I add one thing, one thing? It is you have mentioned and then examination, the introitus is widened, right? And here the genital hiatus is 4 centimeter, 4, and then there's no enterocele and no rectocele. Then what could be the cause of widened hiatus over here? And what is an implication of this widened hiatus? It's very important.
This
And you
can
said
lead
the
to repeated
perineal body
cycle.
tone is also normal. This is something, you know, it's making me alert about these things, about
But
your
the perineal
findings.
body
Yeah.
size is less. So
Perineal
not
body
choreographic.
tone is normal. Yes, perineal body tone is normal.
Size is the total length.
Yes.
Where is the tibial?
6.
TVL is 6.
TVL is 6. Okay. TVL is 6. Okay. So I think, yes, you have a question, but there are variable degree of, damage to the perineal, the posterior vaginal wall, the vaginal wall, etc. So it is possible to have this kind of a finding, but the only thing is that the classification according to clinical examination and the POPQ doesn't match here.
Yeah, that's what my worry is here. So be careful when you're doing something, your clinical examination finding and the POPQ should match.
Yeah.
That indicate either your clinical examination is wrong or your POPQ is wrong.
Yeah.
Okay, you can go ahead next. So that's all fine. You can go ahead. So that also we can have the discussion more. Go ahead.
Yeah. So now we come back to the question that what do you now propose next?
This is a case of a perimenopausal woman.
The diagnosis
So-
is clear. I can see on the screen. Please answer Dr. Ashi's question here.
We can give her 2 options if she wants to go for a conservative one or she wants to go for a surgical one. In case she wants to go for a conservative one, then we can ask her to do pelvic floor exercises and also pelvic floor exercises. And then if she wants to go for a surgical one, we can tell her about the possibilities of surgery that she can go for uterus preservation, as well as she can go for removal of uterus, as she is already perimenopausal and her family is complete. So if preservation is desired, we can go for anterior colporrhaphy and pectopexy, sacrohistropexy or sacrospinous histropexy or sling operations. And if the removal is desired, then we can also go for vaginal hysterectomy along with anterior compartment repair, that is wall along with wall suspension.
See, I am bit differing about your decision, you know. If she is a 45 years completed family, she wants to preserve the uterus, I'll prefer a Farthingale surgery for her. I won't go for the sling surgery at all or the pectopexy sort of thing.
Sarita, before we go into all this,
Yeah.
one, I would like to ask you that she is perimenopausal. I want a bit detail about her menstrual history. Whether any problem is there with her uterus or not, that has to be determined. And also the size of the uterus, the ultrasound findings. So I think that a bit detail of the menstrual history. Could you go back to the menstrual history and show us what you have got in the menstrual? Yes.
Her menstrual history has no remarkable finding. She has a very regular cycle of 28 days and bleeds 4 to 5 days a month.
Okay.
And it is mildly painful, but not associated with any clots.
Okay. So there are absolutely,
and also,
absolutely.
Also, USG findings. Yes.
Yeah. Okay. Can you refer to the USG findings, please, now?
One more thing I will tell you, when you are in the PGs, you don't have to scroll back your case sheet. You should be able to answer immediately.
Yes,
Yeah.
You're not allowed to keep your case sheet with you in exams. Huh?
Even they are not allowed to go through the records because the records will be taken away by the examiner, right? Okay. So where is the ultrasound findings?
So it is written uterus size is 7 into 5 into 4 centimeter. It is written in the investigation part, sir, this one.
Okay. Okay. Upper abdomen normal, right and left ovary normal, adnexs are normal. Endometrial thickness 10 millimeter, uterus 7 into 5 into 4 centimeter in size. Okay. So fairly commonplace findings. Okay. So now you tell me there is no pathology in the ultrasound in the uterus. So you cannot really blame the central compartment to be causing that. So I think in retrospect, I would like to say that it's an anterior compartment defect, which is responsible for the slight or mild degree of descent of the cervix. And also repeated childbirth has led to this. So now you just now tell me how you counsel with the woman about the future. You were talking about some conservative surgery. Okay. Now, what are the moving points or other motivating points for accepting conservative surgery? What do you think?
The menstrual function will be there as she has no complaint with the menstrual problem. And also her reproductive and coital functions will be good having the conservative surgery. And these are the main motivating points.
Okay. So a lady who has given birth to 3 children at home delivery or 2 children at home delivery, and do you think these are special motivating points? And other thing is that any counseling about the sterilization or family planning methods you have to do. Fine. Now you have to ask her, what does she want? Is it a very distressing situation for her? I mean, she complains of just something coming down per vagina. That's all right. But can you convince her that conservative treatment with exercise will be able to restore the normalcy or near normalcy in her case, with the combination of good diet, a good exercise, etc., etc. In this particular socioeconomic status of the woman, there was a contrast there also. She is coming from the upper middle class family, and yet she had 2 home deliveries by DICE and one
upper low, sir.
Upper low.
Lower class.
Upper lower class. What is that?
So they are talking about the Kupus scale, very complicated scale, you know. So I just want to know, here you have done the USG whole abdomen, you know, what is your concern when you're looking for the abdominal USG in your grade 4? As per you, it is a grade 4, I don't know, it is a huge cystocele. What you want to look for an abdominal USG? Because they have some implications. What is that? The patient does not have urinary complaint, that is again a little bit not digestible sort of thing, but still, if you don't, she doesn't have. Abdominal USG, what you are concerned about, that matters for me.
As patient is having age group of 45 years, there are possibly chances of having other complaints as well, like hepatomegaly.
With
Like,
the huge cystocele, with the huge cystocele, there can be kinking of the ureters, you know, and that can lead to hydroureter. And then your urinary kidney function test also becomes important. And then when you're performing the cystocele surgery, your concern should be the chances for the injury to the ureter also is there. And then with this huge cystocele, usually the patient have the manifestation of SUI. And for that, the SUI manifestation is hidden. So you reduce the cystocele first and then test for the SUI. Otherwise, what will happen? You'll repair the cystocele and she will have the manifestation of SUI later. Okay, so this is an important, after reducing the cystocele, the SUI test is being performed, that needs to be mentioned. And then the USG to look for the hydroureter, hydronephrosis. And if you find something, you can have the preoperative cystoscopy or intraoperative cystoscopy. And sometimes even you need an IVP also. IUP is very rarely required, but sometimes, but the renal function test has to be done. Clear? Okay. So you have planned, finally, what decision?
Yeah. And
conservative or?
What are your points? But you have mentioned about the conservative treatment, and I hope you can convince the woman, but suppose you cannot, then what are the points in favor of the surgical management?
There will be a permanent method. So even if we go for a conservative uterus preservation and later on she has some problem with uterus, then she will again have to go surgery for the secondary setting. As she is only 45, she might get uterine pathology later on. And also, if there is only anterior colporrhaphy is done, later on she might have vault prolapse. She might have the recurrent prolapse, or the cervix may prolapse further downwards with an uterine prolapse. So she might need another surgery later on. For
So
that,
recurrence is an issue.
Yes.
We agree with that. Recurrence is an issue. Okay. Anything else with the conservative surgery? I mean, conservative surgery means uterus preserving surgery. Recurrence is one issue. Okay. Okay. So, in absence of anything of this sort, then we'll go for the other part. That means the other surgery is, suppose she is not very much eager to preserve her uterus, then what is the surgical treatment you're going to offer, which happens in most of the cases?
We can ask her to go for a vaginal hysterectomy with the anterior pelvic floor repair.
So with the no fault of the uterus, it will be sacrificed for the theoretical apprehension of it causing more prolapse, isn't it? Okay. So, Sarita, you want to ask something else?
We have time now.
Yeah, we have time.
Okay, now I'm just asking to you that she has on a cystocele, as you mentioned, and you have mentioned there's no site-specific, posterior wall में defect नहीं है. Can you tell me how you differentiate the apical cystocele, central cystocele, and the lateral cystocele on your PS examination?
Differentiation, yes.
It is very important because the level of defects, when you're talking about the conservative surgery, so these things becomes important for me.
Yeah, we will now focus on these issues because in the previous case we have discussed about the sling surgery and associated issues, etc. We won't discuss on them, but this cystocele issue is very important here in this case.
Vaginal rugosities can be tested. If it is a central defect, then the rugosities will be lost in perspiculum examination.
Yes.
And if it is a lateral defect, then the rugosities will be present.
And the lateral sulcus will be obliterated, and then your sponge test will be there. Then how you diagnose the apical cystocele? Because apical cystocele is basically the vesicovaginal fascia which is detached from the pericervical ring, And then apical cystocele usually remains unmanifested, but after you correct the it happens when you're doing the conservative surgery, we just correct the central cystocele. Now the apical cystocele bothers the patient. So for that, if you're finding a bulge high up in the anterior fornix, just in front of the cervix, you should think it's an apical cystocele, and then the vesicovaginal fascia needs to be attached to the pericervical ring. That is important. And in the lateral cystocele, you have to attach the vesicovaginal fascia to the arcus fascia tender vaginalis. And the central, you had to do plication of the vesicovaginal fascia in the center. Okay, now I just want to know from you, correcting the angiocolporrhaphy, the bladder is opened and the urine started coming out. What you will do?
Bladder is open, urine.
It is very smart answer. Go ahead and tell. Don't be afraid of. हम लोग examiner ऐसे ही होते हैं.
Police.
It's a very simple. Don't get nervous. Please come on and tell.
What was the question like?
I just asked if the bladder is open when you're doing the angiocolporrhaphy and the urine is trickling, what will be your next step?
Okay. So you have gone into complications, right? But we would like to hear from them what are the possible complications in this vaginal hysterectomy with pelvic floor repair, which we frequently do in such cases.
Immediately, there can be hemorrhage during operation. There can be hemorrhage. There can be injury to the bladder, and injury to the other structures like rectum or ureters.
Later on, there can be infection or any vault prolapse chances are also present.
And also,
Okay, you told that the vault prolapse chances are there. Your plan for going further vaginal hysterectomy plus entry posterior repair. What precaution should be taken to take care of the vault? We have very less.
Vault suspension.
What are the different methods of vault suspension?
sacrospinous.
So sacrospinous fixation is one thing which we usually do in a procedural prolapse simultaneous करने का है. But when we are doing the VS simple, then what? How do you give the vault support? That is important. Uterosacral, you do a good uterosacral support, attach it back to the vault, and then you have to take care of the enterocele nicely. For that, you need an internal cordoplasty and external cordoplasty suture very well to prevent the post-operative vault prolapse.
What are the sutures you take for the uterosacrals?
So we take on the uterosacral, we take one and proximal and distal, a non-absorbable, no, absorbable, but late like bicrylos, and one proximal and distal suture we take on the uterosacral, and then we bring it to the vault, and then tie it separately, the proximal and the distal.
In your TLAN books, it is very well described the Heaney's method of vault suspension. Can you tell me what is the Heaney's method of vault suspension? At least this method you should know.
I think you should know about McCall's caldoplasty in detail. In the the ways where you can take the stitch, which is very effective, and the external McCalls and the internal McCalls, how do you propose to take and fix where?
And you should also learn the Heaney's method of vault support. And because whenever you're doing this with this huge prolapse, you should do an Heaney's method of vault support, right? And the internal, Dr. Ashish, if you permit, I can just tell this what is the internal caldoplasty and external caldoplasty, how it differs.
Yeah, go ahead. Just tell them.
So in the internal caldoplasty, you take the one, you go as high as possible. You take from the uterosacral, then you take the peritoneum, posterior peritoneum as high as in the cul-de-sac, and then the other uterosacral and tight. In this way, you go on taking 2 or 3 rows of the sutures, and then whatever the extra peritoneum is there, that is excised. While in the external caldoplasty, you take the sutures from the uterosacral and the vaginal vault, that cut end of the vagina, then to the other uterosacral and tie. So usually this external 1 or 2 and then internal 3-4 rows of the sutures are required if you really want to obliterate the enterocele pouch. And then open method is when you're doing the abdominally, it is in a Moscowitz surgery.
Yeah.
And then you have a difference in the Halbin surgery and the Moscowitz surgery. You know the Halbins? What is the Halbin? In Halbin, we fix up with the rectal wall. Okay? The peritoneum which is attached to the rectum also is being taken. While here in the Moscowitz, we don't go up to the rectum. We just take the posterior cul-de-sac. Okay.
Yeah, and before that, the reduction of the redundant peritoneum, I mean, keeping the head low down position and then dissecting the enterocele sac and then pushing it inside the abdomen is important before you put this McCall stitches. So prevention of this thing, vault prolapse, is today it's a major concern these days because we are seeing many cases of vault prolapse after the hysterectomy operation, either abdominal or with vaginal hysterectomy. There was a common misconception that doesn't happen after vaginal hysterectomy, but that is not right. That's also happens. Okay. So
and I just want to make a special mention. Nowadays, we are doing the TLH, total laparoscopic hysterectomy. And such cases, usually the vault is vulnerable to get prolapse if you fail to recognize the enterocele because it is an apical defect.
Yeah.
And if you fail to correct the apical defect, definitely this patient is more likely to have the wall prolapse in the future. So when you're doing the TLS, be concerned about your apical prolapse. Now I think, sir, we have the last question for that, something which the students don't read. Is that because it is being obsolete or not used? Some role of mesh surgeries in the prolapse uterus, you can just tell something about that. When it has started, how it started, and why it has been stopped, and what are the current day indication for this mesh? And what is apogee and what is perigee? Ashish, it is very difficult, yeah? We can handle.
Actually, we have stopped asking these questions, apogee and perigee these days.
No, I'm not concerned. What is the current day role of the mesh is important. Because a muslin tape itself is a mesh. Mesh, it is allowed. Then you are using the sacropaxis, colposacropaxy, where again you are using the mesh. It is permitted. Okay, and then if you have a known connective tissue disorder in a very fragile women, still there is a mesh. Of course, the risk of mesh erosion is there, but if you do in a right way and using a smaller size mesh, still you can help the women. So that is important. You have to individualize. You can still have the role of the mesh in the vaginal surgeries, you know.
Some of the
type 1, type 2. I'm not going to ask the type 1, type 2, and type 3 mesh, Ashish.
Yeah, okay. No, some of the vaginal surgeons also perform vaginal sacrocolpopexy in the running case. That means with the vaginal hysterectomy, they're also justified unilateral or bilateral. More commonly, they go for the unilateral in order to prevent the future wall prolapse.
Yeah, that is again a very good, the sacrospinous fixation in the procedentia or the huge prolapse. You should do a prophylactic unilateral sacrospinous fixation at least. Okay, yeah. Ashish, you have just put one thing, you know, sacrospinous fixation. What are the vessels and the nerves we are then vulnerable to get injured when you're doing the sacrospinous fixation? You should bother about certain vessels and the nerves.
Vessels and nerves, yes. Have you seen this sacrospinous fixation?
Achha, can you tell me what is sacrospinous fixation? Where, what is fixed where in sacrospinous fixation? Tell me the points only.
It's fixed on the promontory of the sacrum.
Sacrospinous fixation, we're not talking about the colposacropaxy. Promontory, we are going for the colposacropaxy. Here I'm talking the sacrospinous fixation. And sacrospinous is in a ligament. And we fix the vaginal wall to the sacrospinous ligament, 2 centimeter lateral to the ischial spines. Sorry, 2 centimeter medial to the ischial spines. Then what are the nerves who are traversing through your ischial spine? What are the vessels which are traversing through your ischial spines? What are the vessels going through that sacroiliac notch? Just remember the anatomy and you'll get the answers.
Pudendal structure.
So this is the pudendal nerves and the pudendal vessels which are there, which are highly vulnerable. That's why we are a little bit medial to the spines, the ischial spines. And then sacroiliac notch, which are the vessels going through the sacroiliac notch? These are the gluteal vessels. And then again, you have a rectal pillar over there. You can injure the rectum and the rectal pillar. If you go more medial, then you can damage even the hypogastric nerve plexus. So be aware about all those things. Okay?
It's mainly the pudendal vessels and nerves. And there was a question about the bladder repair, how to repair that. I can mention about that they just do a liberal dissection of the bladder from the underlying tissues and then repair it and then go further for the. It's not a very alarming procedure. It's a very important thing to learn about this bladder repair. Ideally, we say that you can do it in 2 layers, but in some situations, it can die in one layer repair also. It doesn't really matter, provided the postoperative drainage is quite good, you know. And previously, we used to depend upon 2-way drainage of the bladder. Nowadays, we are not doing them. We are not having any suprapubic catheter. Sarita, are you using suprapubic catheter along with the dependent catheter, or you were just depending on one
When
catheter?
it is an injury from the vaginal side, we don't use then a suprapubic catheter. Suprapubic is required only with the dense adhesions endometriotic surgery, when you have actually damaged a large part of the bladder.
Yeah,
And you are, then only it is done, otherwise not required.
the urologists
But the
also
most,
nowadays.
yeah, they don't, yeah. The most important thing is whether you had got an watertight closure or not, that matters. So always after doing this repair, do a methylene blue test.
Okay, so I think we have more or less covered everything. Is Dr. Ashok Kumar there? Monideep, you want to comment on something on your case? If you want, you can.
Yeah, thank you very much.
Addition or subtraction or any changes?
No, it's not changes. I just want to put forward what we have done for this case.
Yeah.
In a real case, we have a patient wants to have one of the uterus. So we have done vaginal hysterectomy with anterior repair, the usual central cystosil repair. Along with that, we have done the extraperitoneal high uterosacral ligament suspensions. Actually, what my PGT was describing, that's my they are describing, which I've invented and published in the International Urogynecology Journal also. It's a new technique. We used to put the cervix on the tractions, and then we expose the bilateral uterosacral ligaments, and we go up to the intermediate level of the uterosacral ligaments, almost 5 centimeters we can expose, and we increase the bladder and by the Landau's retractor, so they are not coming to the field. And the top one, what you said, that top one we take with the Prolene sutures, and just 0.5 to 1 centimeter below that we take the biplanar sutures, and after the rest of the techniques, whatever all of you are doing, we are doing the same things, the VH. But while coming back the repair one, we just both the sutures, they have the two limbs will be there, no? Anterior and posterior. So anterior will go via the vesicovaginal septum repaired area, and the vacuole will come out through the vaginal mucosa, and the Prolene will not come out through the vaginal mucosa. So the posterior also same. Vacuole will come out through the posterior vaginal mucosa, but Prolene will not come out through the mucosa. It will go through the only septums only. The thing is that we put the vacuole in the laterally and the Prolene in the medial. When we'll fix the catheter. As a result, the uterosacral ligament will come and fix to the wall like a T shapes, and ultimately they will give good support. So with this technique, we have done many cases, and most of them they are doing well. Those who have come to follow up to us, none of them any recurrence of the prolapse. Others are still in the follow-ups. So if you once, you can also try these techniques. The techniques as a videos is available in the IUJ, International Urogynecology Journals. Whole description of technique as well as the video, both are available in that journal. So it's a very nice technique. Everybody can do it. And initially, the Professor Peter Dwyer from the Australia, he has invented this one for the valve prolapse. So he was doing for the valve prolapse as a treatment, but I am doing it for the
prophylactically
prevention. So we're getting a very good result.
So essentially, what is it that actually you are keeping the Prolene inside the peritoneal cavity, and you are taking out the vacuole through the vaginal wall. You are not allowing the Prolene to come out through the vaginal mucosa and cause irritation. That's what you mean, actually.
Absolutely, absolutely.
Okay. Okay, so I think that's a good modification, and we should try that. Dr. Ashok Kumar, would you like to comment on this? Are you there, sir?
So Dr. Monideep, thank you so much. We will love to see your videos,
Thank you, ma'am.
It's really good, and your PGs are lucky to have you over there inventing something new.
Yeah, thank you, ma'am.
No, that is the old this thing, that belief that we have been carrying so far. We are doing these modifications, little bit of modifications, and what impact they're having on the repair of the postoperative period, healing, etc. Then we need to, always follow it up. Yes, Dr.
And Dr. Ashok Kumar is being muted.
Yes.
Can he's just requesting to unmute him.
So,
yeah, he's unmuted now. Yes.
So if I am not able to see any queries also in the chat box.
Yeah.
So what I can do is that I thank all my teachers and experts for today. Tutorial, Dr. Sarita from Raipur, Dr. B.R. Sharma from Mandi, and Dr. Rajkumari from Imphal, Dr. Neelama Patil from Bijapur. And I also wish to thanks Dr. Geeta from Sri Ramachandra Medical College, Chennai, and Dr. Mandeep Paul from College of Medicine and JNM Hospital, Kalyani, West Bengal, and all our students from these two medical colleges and all our participants who have been here with us for today, Sunday morning. And it was a very good discussion about prolapse, and always I feel that prolapse is a topic which always needs to be refreshed every time, because we have a lot of discussion about these things, and probably we have left something we can plan for some in one of our next tutorial about more of laparoscopic surgeries and all those things. But I think this is the basic which is required for the students, which we have discussed, starting from the history, the important points in the examination and the classification and the management part, which is very important. And just we have also touched upon the etiology, why prolapse occur and what are the factors responsible for this. So I express my sincere gratitude from FOGSI ICOG to all the experts, teachers, and the participants. So thank you very much. Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman are also the pillar of this program, and they always plan and see to it that the message is conveyed to the students in a correct manner. And we all three have the emphasis that basic obstetrics and gynecology should be conveyed through this program, and we should emphasize on history taking, examination, and summarization of the case. And obviously, diagnosis and workup is another important step in the management of the patient. So thank you all. In the end, I wish you all the best, and we will join you in next Sunday, the second Sunday of the month, in the month of March, again with a few more topics and cases for discussion. And I just remind you, all of you, that the recording of all our program, including this one, will be available on the ICOG website. You can visit the website and access to all our previous program also. So thank you very much. In the end, from FOGSI ICOG, good day. Thank you.
Thank you so
Dr.
much.
Ashok Kumar, if you can permit, I can just give some concluding remark for the
Yes,
message, as a part of the message to all the PGs over here. See, whenever you're having a case of the prolapse uterus, you have mentioned about what is your diagnosis, what is the degree of prolapse, and what is your POP2 classification. Apart from that, what are the etiological factors, and what are the predisposing factors, and what are the associated gynecological condition, and what are the associated medical conditions. If they are there, then that also has to be included on that. And then it is not directly jumping to the surgical intervention. We should always talk about some conservative. We have not discussed here what are the pessary, role of the pessary treatment. And of course, in this case, it was not there, but we could have discussed what are the different types of pessary which can be used, and what are the role of the pessaries, and what is specifically the supporting pessary nowadays, and what are the pessary when it is an associated SUI is also there. And then again, what are the predisposing factors needs to be addressed. If she has a chronic cough, I could see in your case, so that needs to be addressed. Otherwise, your surgical outcome may not be good if you don't address that thing. If she has some chronic cough and chronic constipation, that has to be taken care of. That should be also mentioned. And then apart from that, the post-surgical advices to the patient, what should be there. That is very important, you should mention about. And what are the if you want to decrease the overall incidence and prevalence of prolapse, what are the intervention which you are going to take? That is very much important. So managing obstetric does not start with taking care during labor only. You start from the family planning services, the good antenatal care, the good intrapartum care, and the good postpartum care. So you should be able to elaborate at least 3 and 4 points in each of the case. And I congratulate the PGs from both the centers who did well. And thank you so much for being with us and benefiting other students. One query, Kalyani, do you have the school college dress in your students? Because I can see the both the students and the one dress. Is it?
This is the apron, lab apron that we
So
are
you have
having.
a different type of apron with a blue collar, looking nice. Thank you so much.
Yeah, and I think we will close it here, and with the message that we need to have more and more discussion today. We didn't touch, like for instance, stress urinary incontinence. We haven't discussed much. We haven't discussed about the conservative management of prolapse, and but we have managed to discuss the correct role of mesh surgery today, and the usual approaches. And as it is a clinical discussion, we always have insisted upon the correct diagnosis making through the well-established clinical process of history, general examination, physical examination. I think if that is the foundation or the building block of a case presentation, then the students will easily pass, following upon which we can always build up more marks for that particular student. So I think that we will discuss more and more with all these things. And as Dr. Ashok Kumar said, that the prolapse need to be revived every now and then, because new things are coming up and new things are being added, with the new systems being criticized or improved upon. So I think that we will need more discussion on that. With that, thank you very much. We'll close today's discussion here. Thank you everyone for participating in the discussion. Thank you so much.
Thank you.
Thank you, sir.
Komalji, please stop recording.
Yes, sir. Yes, sir.
So thank you very